Good morning, everyone, and welcome. And thank you very much for joining us today for our virtual conference focusing on the issues and concerns of children, young people and their families living with an acquired brain injury. My name is Joe McVey, and as Chief Executive of Brain Injury Matters, it's my pleasure to have been asked to chair today's conference. In that capacity, I wanted to draw your attention to three items. Firstly, to the Zoom guidelines for today's conference, which you would have seen on the slide earlier. Secondly, to encourage you to engage as much as possible in today's conference by posing questions or comments using our question and answer function. As you'd appreciate, it's a very busy day, so we'll try and get to your questions as much as we can during the day or during the sessions. And if not, we'll make sure your questions are reflected in the conference summary. And also, if there's particular issues or questions, I'll ensure that our staff team come back to you as soon as possible. And thirdly, I'd like you to promote the conference and sessions which are of particular interest and relevance, which you think might be of interest to your colleagues, using our conference hashtags. That's BIMConf21 or hashtag AIBConf21. Thank you for your attention. Thank you for joining us today, and I hope everyone has a really interesting and enjoyable day. And to start the formal proceedings off, I'm going to pass over to my chair, Mr. Gordon Gough. Thank you, Gordon.
Thank you, Joe. Thank you, Joe. As Joe said, just like to welcome you all to today's conference. As you know, the title, Developing Services for Children Living with Acquired Brain Injury, Good Practice Opportunities and Challenges. And as you know, the conference is hosted by Brain Injury Matters in conjunction with the Belfast Health and Social Care Trust. We have a host of terrific speakers working in the field of acquired brain injury here in Northern Ireland, the Republic of Ireland, from health, education, and the voluntary and community sector, all sharing best practice and learning. We're honoured to have our Health Minister, Swann, giving the opening address. As you can imagine, Robin has lots of pressures on his time at the moment, so we are especially thankful that he's taken the time to join us here this morning. As Health Minister, Robin understands only too well the profound and life-changing impact that an acquired brain injury can have on those children who suffer brain injury, their families and loved ones. Today we also welcome the parents of children and young people who have an acquired brain injury. We'll hear later on their journey and their experience of services in Northern Ireland, what has helped their children and young people and what more could be done. I got involved with Brain Injury Matters after our daughter was seriously injured in a road traffic accident and suffered a severe brain injury. So I guess I know firsthand the impact that had not only on my daughter but also our family. Brain Injury Matters provided us with support and information to help us make sense of the situation. And as so often happens, I got involved with the charity and was honoured to become chairman back in 2017. Since 2013, Brain Injury Matters has been working and supporting children, young people and adults with an acquired brain injury and their families right across Northern Ireland. And I've been delighted to see, along with the board of directors, just how Brain Injury Matters has developed since then, focusing on the growth of services for children, young people and adults. In 2015, I think I'm right in saying there was no regional service that worked specifically with the whole family to help them cope and come to terms with the impact of an acquired brain injury. So Brain Injury Matters developed our Family First service in partnership with the Belfast Health and Social Care Trust, and has developed and delivered that family-focused model of care, and indeed has been independently evaluated and has been shown just how it improves the lives of children, young people and their families. I've often said that a brain injury is referred to as a hidden disability, and I certainly see that manifests itself in various scenarios with our daughter and our family. and I'm sure the families we hear from later today will have similar stories to tell. I often think acquired brain injury does not have the profile that perhaps other illnesses have. I'm thinking of cancer, heart disease, diabetes, etc. And we've discussed that as a board of directors within the charity. But I know the team in Brain Injury Matters and everyone involved, we have a passion to improve the lives of those affected and their families, to raise the profile of brain injury, to lobby for greater awareness, to see constantly improving services, and act as an advocate for those with an acquired brain injury. I'd just like to pay a special tribute to Joe and the team in Brain Injury Matters for all the work they're doing in that field, and particularly over the last 12 months, which everyone knows has been particularly challenging. And acquired brain injury is for life, and as a society, I think we need to learn more and channel more resources into support services, research, lobbying and advocacy. Today's conference hopefully is a step in the right direction of raising awareness and looking at best practice. And I want to thank all those involved in the organisation of it, and to the speakers and families taking part. I know the Brain Injury Matters team has been working hard over the past few weeks, along with others, in pulling it all together. So look, there's a lot to get through today. So I'm going to hand over now to Dr. Sarah Meekin, Consultant Clinical Psychologist and Head of Services at the Belfast Health and Social Care Trust. Enjoy the rest of the day, everyone. Thank you.
Good morning, everybody. So I'm delighted to be with you this morning and delighted to see so many people joining us, and hopefully you will all be able to stay the day. It's a pleasure to be able to be hosting this conference with our partners, Brain Injury Matters, and we've had a great relationship over the last number of years. And it's great to be able to give a voice and time also to consider the needs of young people and their families following the experience of an acquired brain injury. It's also important that we open this week as Mental Health Awareness Week, and never has this seemed more important than in the following last year that we've had, a year of challenge for every one of us, but how much more so for children, young people and families who've had to manage the sequelae of brain injury on top of COVID, whilst also having less resources and possibly less supports and trying to homeschool. An acquired brain injury changes lives. It changes families, and life is never the same. You will hear directly this later today as we hear the stories of young people and their families. For us all as parents, professionals, as volunteers, the daily challenge for us is to how do we celebrate our young people in their difference whilst also supporting them, embracing their quirks and challenges, strengths, and as my daughter would say, their personal awesomeness. An acquired brain injury layers additional difficulties onto this normal life milestones. And I'm delighted to look forward to hearing later about the work of Youth Matters Empowerment Programme, providing that extra support and guidance to teens and young adults as they navigate their lives' goals and choices. The Belfast Trust Psychological Services have a long history of partnership working, and it's incredible to look back and consider that this particular project with Brain Injury Matters is 6 years old. Over 6 years, we can still reflect that there's a paucity of services for children with acquired brain injury. We have no dedicated inpatient rehab units and no specialist community services for children as yet. We hope that days like today will continue to highlight the ongoing need for service development. However, it's also really encouraging to reflect on the partnerships developed and the onward journey to progression. I feel as we work and look through the programme today, and we have a chance to hear the stories that'll be told, we can see that there have been many keen to support children and their families, and that many have moved from their corners towards each other. It's really encouraging to see presentations from such a wide range of services across such a wide range of sectors. We can see health, education, charitable sectors all working together to build upon each other's knowledge and expertise to make a day a little easier for those living with acquired brain injury. I'd like to welcome Minister Swann and be very grateful for his time and for his support in this area, in particular his interest and support in mental health and well-being across all sectors of life and community. We've appreciated his leadership over the last challenging year, and we look forward towards a post-COVID recovery with his continued leadership to support children and families, and indeed staff, in their ongoing journey with acquired brain injury. You will notice a Winnie the Pooh theme to my slides. Partly that comes from my paediatric psychology roots, but also over COVID, we did some house cleaning. It turns out you can actually get bored with Netflix, and rediscovered some childhood favourites. My father was a big fan of A.A. Milne, and I can still hear his voice reading the books and poems. Whilst looking through some of those books, this poem struck a chord. Perhaps it was a bit in relation to their journey through COVID, but I also felt, in looking back, it was possibly a good reflection today. Today we have an opportunity to look back upon what we have done, halfway down the stairs, if you like, to review the progress that have been made. But as it says, we're not quite at the bottom. We have an opportunity to look also downwards or forward and to plot a path that still needs to be taken. And so I look forward to hearing the work that has been done and is ongoing, to continue to raise awareness, to review the progress that is being made, but also to view the path that still remains ahead and the work that we all still have to do together in supporting our children, young people and families living with an acquired brain injury. I hope you enjoy the day and look forward to spending time with you all.
Thank you very much, Sarah, and thank you to Gordon for your opening address. And I think clearly from Gordon and Sarah, the themes of partnership working are obviously extremely important in setting the framework for today. Gordon's reflection, I think for a lot of families, it's very much based on personal experience. And while we describe ABI as a hidden disability, I think for families, and as Gordon reflected on, it's a very real disability to live with and impacts upon the family and everyone connected with the family. So I'm delighted to Gordon, and thank you Gordon and Sarah for setting the tone. It's my pleasure now to introduce the Minister for Health for our Northern Ireland Executive, Mr. Robin Swann. As Gordon and Sarah have said, we're delighted that the Minister has joined us today. I'm very much aware of the demands on his diary. In fact, it's great that Robin's joining us because he's actually held this in his diary, I think, on 3 occasions due to various cancellations. So it's a pleasure that Robin's taken the time to be here, given the demands on him. So I want to just say a very personal thank you to the Minister and hand over to hear his opening address. Thank you, Minister.
Thank you, Joe, and good morning, everyone. I would like to begin by thanking Joe for inviting me to deliver the opening address today at this important conference on childhood acquired brain injury in Northern Ireland. I'm delighted to be here, albeit in a virtual capacity, which I am sure all of us have had to become accustomed to during the last very difficult and unprecedented year. And as Minister of Health, I'm fully aware of the life-changing impact that an acquired brain injury can have on those children affected and on their families, their friends, and all those who care for them. Today's conference will provide you with the opportunity to hear from a wide range of clinicians, professionals, and the voluntary sector involved in the treatment and care of children living with the effects of an acquired brain injury. In my role as Minister of Health, I acknowledge the vital role that the voluntary and community sector play, working in partnership with the health service in delivering health care and a wide range of services right across Northern Ireland. Brain Injury Matters is a good example of such partnership working. The Belfast Health and Social Care Trust, for instance, entered into a partnership with Brain Injuries Matters in 2015 for the Family First project, which was funded by the National Lottery Community Fund. This project aimed to support the whole family by promoting the acquisition of skills to meet the challenges associated with being a parent of a child with an acquired brain injury. And at this point, I think it might be helpful if I talk about our current services for children affected by acquired brain injury in Northern Ireland. As you may be aware, the paediatric neuropsychology service in the Royal Belfast Hospital for Sick Children provides support to children and young people who have medical conditions that may affect their brain and development. This includes traumatic brain injury. Among their range of supports, this service provides help in identifying learning needs that may have arisen as a result of a brain injury. These include supporting changes in behaviour, helping families cope with the adjustment to brain injury, and promoting the development of new problem-solving skills. There's also the Children's Acquired Brain Injury Consultation Service. This is a multi-professional service consisting of sessions from clinical psychology, occupational therapy, and speech and language therapy. This is provided as a regional service which provides advisory and consultative support to existing services for children and young people with an acquired brain injury. Very understandably, a frequent concern for families following an acquired brain injury in childhood relates to the potential difficulties faced on the child's return to an educational setting and indeed their educational attainment. So in order to address these issues, a new partnership arrangement between the Children's Acquired Brain Injury Consultation Service and the Education Authority has recently been developed. This partnership will allow for the delivery of tailored training aimed at supporting schools to manage the various challenges associated with an acquired brain injury in children. In addition, organisations within the education sector can access the very valuable expertise of allied health professionals in the children's service via consultation. Unfortunately, the COVID-19 pandemic has proved very challenging to everyone involved in delivering services, given that lockdowns and social distancing requirements called for a change in the way that services are provided. For example, the use of virtual therapy was employed to allow support for children and families to take place remotely where this was appropriate. The physical, sensory, communication and cognitive difficulties that are common in children affected by an acquired brain injury and the requirements for elements of cognitive assessment to be administered in person meant that face-to-face provision continued to be delivered for some. But let us not forget the additional challenges faced by families and carers. As the COVID-19 restrictions brought about the closure of schools and a wide range of activities, this resulted in families who care for children with physical and emotional needs losing opportunities for short breaks. Children learn through play, and as unfortunately we have seen, social contact and activities became much more limited as a result of COVID-19 restrictions. This is particularly challenging for children with an acquired brain injury who are already vulnerable as a result of that injury. At the Regional Acquired Brain Injury Unit at Musgrave Park Hospital, measures adopted during lockdown included a period of virtual liaison, working collaboratively with the neurosurgical team during the height of the pandemic, along with continued inpatient rehabilitation services. They've recently recommenced face-to-face appointments in general clinics with reduced numbers of patients in the spasticity clinic to comply with social distancing and reduce risk. The neuroscience unit also continued to provide a service during the pandemic, although at a reduced level. The service has handled increased requests for information from community brain injury teams and hospitals as they return to face-to-face provision and address their waiting lists, which have increased due to the pandemic. Patients who need urgent face-to-face appointments were seen by both neurosurgery and neurology teams, resulting in an increase in virtual outpatient activity. And I would like to pay tribute to the work of our community rehabilitation brain injury teams, who throughout the pandemic continued to offer goal-directed, team-delivered brain injury-related rehabilitation. And I would like to conclude with a few words on my plans for the future of neurology services in Northern Ireland. My department's ongoing regional review of neurology services aims to identify the optimal configuration of neurology services for the next 10 to 15 years to ensure that patients across Northern Ireland receive timely access to neurology assessment, diagnosis treatment, condition management, support and rehabilitation. An interim report that was published in October 2019 outlined the direction of travel for phase 2 of the review, which is being taken forward by a number of work streams, each led by a member of the review team. Unfortunately, work on the review was paused in the short term to redirect resources to fight COVID-19. And while I believe that this was the right thing to do, I am acutely aware that neurology services are in need of reform. Therefore, I'm keen the review should restart in the coming weeks. Going forward and working together, we will continue to help to address the many daily challenges faced by children with an acquired brain injury. And I hope that this timely conference will help to further raise awareness and understanding of this important issue. And finally, I would like to take this opportunity to thank everyone involved in the conference and wish you all a very successful, informative, productive day. And thank you Joe.
Thank you, Minister, and thank you for your very helpful and insightful comments. We're delighted, I think, to hear your references to partnership working and also reflecting on the challenges we've all faced during the COVID period and how services were very much turned on their head, but pivoted, I think, very successfully to try and continue to meet the needs of children and young people. And again, your last reference to the review of neurological services, I think we're all obviously very keen to see that progressing and really looking forward to seeing the outcomes. And from the voluntary sector perspective, if we can help in the rebuild agenda, very, very happy to do so. So thank you very much, Minister. And may I say also on behalf of BIM to thank you for your leadership over the past year and the way you have steadied and led the ship through the pandemic. It's been exemplary. So on a personal level, thank you very much, Robin. Thank you, and good luck with the rest of your day. Thank you. If I may then just move to the first presentation today, I want to welcome Dr. Yunan Mcrudden, who's a clinical psychologist within the Belfast Trust. Dr. Yunan Mcrudden will be known to many of you here at our conference today. He's been a long-time supporter, colleague and advocate of the need for greater services for children with acquired brain injury. We've had the pleasure of working with Yunan over the past number of years. And today Yunan is going to focus on the issue of childhood development and looking particularly at the issue of context and the environment. So thank you very much, Yunan. I'll pass over to you now. Thank you.
Good morning, Joe. Thanks, everybody. Thank you very much to Minister Swann as well. It's an absolute pleasure and privilege for me to talk to you all this morning in relation to context and considerations in relation to acquired brain injury in childhood. I suppose just to kind of orientate, I work as the clinical lead with the community brain injury rehabilitation team in the community here in Belfast. But I also hold a caseload within the paediatric clinical psychology service as well. And I suppose it's on the basis of the experiences in both of those services that a number of the understandings and the observations I'm going to be making with you today have been developed. I know that normally whenever we have presentations like this, we normally make or extend acknowledgements at the end. But on this occasion, I think it's really important that I actually acknowledge a number of groups and of services from the outset. I suppose first and foremost in my career, it's been an absolute privilege and honor to work alongside the children and young people and their families who have come through my clinical caseload. And it's on the basis of those observations that I've seen in working with those families and working with those young people that I have really drawn this understanding that we're going to be talking a little bit about today. I also want to make a special reference as well to the Royal Belfast Hospital for Sick Children. I worked there for the first 10 years or so of my career and still work there. The Children's Hospital is an amazing place with an amazing group of staff teams and an amazing provision that is made. Within that specifically, I want to make reference to the Paediatric Clinical Psychology Service, which has been my kind of work home for quite some time. And the Paul ward as well, which is the acute regional neurosciences ward, and the neurosurgical service as well, who I've worked very closely with over the last number of years. The idea of partnership working has been referenced already on a number of occasions, and I think it's really positive that that is the case. I do want to explicitly acknowledge a group called the Talking Heads Group. They were a group of parents who came together back in about 2013, 2014 maybe, with the intention of supporting each other. They came together as a result of a program that was delivered in conjunction between myself and some providers within the Child Brain Injury Trust. But the Talking Heads Group themselves brought some further additional supports to parents and families, and began lobbying in relation to some of the things that you're going to be hearing a little bit about today. And I think part of the impetus behind it, the Family First project, actually came from some of the observations and the insights that came from that the Talking Heads Group. I also want to acknowledge the role and support that the Child Brain Injury Trust and Brain Injury Matters also play in terms of supporting children, families and young people coming through these processes. Minister Swann has obviously just mentioned the Children's Acquired Brain Injury Consultation Service, and I do want to acknowledge the valuable work that has been done through that service. And I want to specifically mention Lindsay Klamatska, speech and language therapist, and Naomi Brown, who are both heavily involved in us developing that team from the outset back in 2015. I also want to make reference to a couple of the other training providers that work across the region: Stranmillis University College, the Clinical Education Centre in Knockbracken Healthcare Park, and also Queen's Schools of Medicine and Psychology. There have been a number of training programs that I think Katie and Charis will talk a little bit more about later on, and reference will be made to the work that is done in conjunction with those training providers as well. And I also want to acknowledge the role and support that has been played with more recently developed partnerships with the Education Authority, and specifically the Educational Psychology Service itself, who, as the Minister has mentioned, are developing in conjunction with the Children's ABC Service bespoke and specific training in relation to acquired brain injury in childhood for educators. I suppose it probably makes sense as well that I also acknowledge my wife and sons, who probably also know now more about brain injury than most other families do. I want to just say a little about the idea that clinical psychology are generally concerned and look at issues in relation to biopsychosocial phenomena, those things that actually have a biological basis. There's some psychological components to it, and they occur in social contexts. And I think, to my mind, brain injury in childhood is probably the most quintessential example of this. And what I want to take some time this morning with you to do is to think a little bit about those things that happen within the child and the young person themselves who sustains the injury, and then take some time to think about what happens around that child, what happens in those systems, those services, those contexts where they find themselves, whether that's the familial context, whether it's service-related context, or whether it's something a bit broader than that. And I suppose the important thing, going back a little bit to the number of different providers who I've just acknowledged, I think it's important. Anybody who's heard me talking or been to some of the trainings that I've been involved with will probably recognize some of the slides that I use today. And I make no apology for doing that. I think it's important that there is a shared understanding. I think shared understanding goes hand in hand with the idea of partnership working. And I think it's vitally important that there is a communal understanding held between health, education, community voluntary sector, and most importantly with the families of these children who have sustained these injuries that we're talking about today. Gordon has already mentioned the idea and the phenomenon that brain injury is often referred to as a hidden disability, and that is so true. I think in kind of preparing this and thinking a little bit about it, I suppose one of the issues that repeatedly comes up is the fact that in brain injury, the injury is sustained by a part of the body that is actually quite difficult to observe, quite difficult to see because of the fact that it's inside our heads. But I suppose what has happened over the last certainly 20 to 30 years, developments in imaging studies and in clinical science has allowed us to better understand the developmental course and the trajectory that our brains experience. Brains develop from the first weeks first weeks of pregnancy right through until we're in our early 20s. And that phenomenon is kind of borne out in the functional MRI image that's in the bottom corner of the slide here. What we're looking at is a developmental progression in terms of our brain's development that occurs throughout our lifetime up until our early adulthood. Now, I think given what we're talking about here today, which is about brain injury in childhood and children and young people, I think the fact that the brain's developmental course extends out into our early 20s in itself creates challenges in terms of how we actually think about providing the services to the children and young people who sustain these types of injuries. In addition to the idea of the developmental course that the brain goes through, there's also the issue of the fact that whenever we're thinking about brain injury, we typically think of what are referred to as traumatic brain injuries. Traumatic brain injuries being those injuries that can maybe be sustained through road traffic collisions and the like. However, the reality is that while TBI is certainly the most common form of brain injury that we would experience and come across, it's actually only one of a number. Part of the issue then being that while TBI is common, or comparatively common, there are other injuries that are sustained through things like tumor and radiation treatments for central nervous system tumors, stroke and vascular conditions, which can occur in childhood as well in the same way as they happen in adulthood. Unfortunately, we do have children who develop or experience hypoxia as a result of sometimes complications of medical treatment or near drowning or near strangulation. So there are any number of significant ways that brain injuries can be sustained through infection, through surgical procedures, through complications, through accidents. And I think the fact that there is that variety of mechanisms of injury and associated with the variety of mechanism is a variety of different medical specialisms or surgical specialisms that these children will pass through. That in itself creates a kind of an additional consideration in terms of how we think about these children's needs in the longer term. I suppose in addition to the fact that we've got injuries that can be sustained in different ways, we also have the reality that we have injuries that are being sustained by the organ of our body that controls our body. And with that, then there comes a variety and a range of different potential areas of impact. We've got issues that we've got difficulties that can be associated with the motor systems and how the body moves, both in terms of fine motor control and gross motor control. We've got issues potentially in relation to how the person experiences the world through their senses, through their vision, through their sight, through hearing, through taste, through touch, through smell. We also then have, obviously, the ways in which our thinking skills can be affected following on from a brain injury and associated with a brain injury. So how the brain actually processes what has happened, and then how it communicates. How is language formed? How are people communicated with? And in what way are behaviors and interactions then reflective of what has happened to that brain? So we're not talking about things that happen or experienced within a specific area that one particular professional will deal with. And I suppose, again, making reference to the issue of about education, one of the things that is very clear is that actually all of these things can impact on something like how a child accesses education. And not just how the child accesses education, but also how the education providers provide a support and a service to these children, how they educate these children. And as has already been mentioned as well, there is always the risk, there is always the consideration about, well, how does the child actually understand, remember, do they remember the injury and what it has been sustained? And how does that have an impact on their emotions and adjustment? How does that impact on how they see themselves? And how does that impact on how others see them as well? I suppose the reality as well, as we've talked about so far, is that we're looking at injuries that can be sustained in any one of a number of ways to a developing system that actually will control how the human body and how the person is for the rest of their life. This is a slide that I use in virtually all of my training. Not just because it talks about how different areas of the brain develop at different times and over different periods. But the important part is that brain development is actually experience dependent. Now, we're going to come on to talk about that in a moment, but I think one of the things that we need to be thinking about, and we have to be very mindful of in relation to children and young people, is how a brain injury might interrupt what would otherwise be normal developmental tasks and normal developmental experiences. And I suppose there's two very big and important considerations to my mind in this. When we talk about brain injury and when we talk about what happens after brain injury, we're normally focused on what is referred to as rehabilitation. And rehabilitation realistically is about returning somebody to a level of function. Now, the difficulty and the issue that we have to be concerned about with children and with young people is that we're often not returning them to a level of function. We're actually habilitating them. We're getting them to a level of function. When an adult has a brain injury, they can be sometimes rehabilitated back to the level of function that they were at with supports in place. But there's a significant difference where the child hasn't necessarily attained that level of function. And for that reason, we need to think about how services can think about what might be the longer term issues that a child might experience following on from a brain injury. The other side of this is that we still have the very basic considerations that we have to think about as we would with any other health or developmental concern. So for example, I can remember one young man who I worked with a number of years ago who developed a central nervous system infection when he was about 10 or 11 years of age. And when his treatment required that he have his head shaved in order to allow for neurosurgery, and that left him with a shaved head with a large C-shaped scar right in the middle of his forehead. Now, as I said, it happened to him when he was about 10 or 11 years of age. It actually happened towards the end of his P7 year. He missed the end of his P7 year, unfortunately, and wasn't able to rejoin his class. But it also meant that whenever he started big school, he was going to be starting a school without anybody who he knew and wasn't going back into a familiar group of friends. And I remember talking to him, and I remember asking him, I asked him, how are you going to explain to the new people that you have in your class about the fact that you've got a shaved head and a big C-shaped scar on your head? And he said to me, I'm going to tell them that it's none of their business. Now, that to me was a really helpful and reminder of the fact that there is a balance that we need to strike here between what services, what professionals, what families need to know, but also we need to be able to respect the right to confidentiality and the right that the person has to decide about how much is being told and has shared about their condition and about how their condition might impact on them. This is also another slide that I share regularly. So when we move beyond thinking about the child themselves, when we move beyond thinking about what are the things that have actually impacted on them in terms of the injury and how the injury was sustained, it's when we start moving into this area of those things around, those people around the child. This image is an image of the Royal Belfast Hospital for Sick Children. It's taken just outside of their emergency and outpatients department. And the thing that always strikes me about this, I walked past this building or this structure, this statue outside the Children's Hospital for years before I realized what it actually was. If you stand under that flying saucer, you see what were the chevrons of the Northern Ireland Ambulance Service. It actually turned out that it was ambulance service personnel who actually decorated that flying saucer. And it was interesting because whenever I took some time to think about that, but also think about the experiences of people who came into the Children's Hospital via an emergency ambulance, I realized, not least on the basis of some observations that parents made, was that actually the experience of having your child admitted to hospital via an emergency following on from a brain injury and having your child taken out of your care and put into the care of the health and social services for whatever period of time was akin to having your child abducted by aliens. And I think that experience in itself can have huge implications for how people, how families, how parents take care of and see and work with their child following on from the injuries that were sustained. I think that reality is also brought very home to me because of some of the discussions that I've had with parents in relation to the concerns they had about the siblings of the child who was injured, possibly because the siblings actually observed or witnessed what has actually happened to their brother or sister. So there's something very, very important about being able to know that when we're talking about these brain injuries, we are not talking about just what has happened to the child. We need to be mindful of how those people around the child are actually responding, reacting, and understanding what is happening. Again, that very much came to the fore when we spoke to the Talking Heads group and when they talked to us about what they felt was missing, what they felt would be important, what they felt would be helpful in terms of meeting their children's needs and meeting their own needs following on from these types of brain injuries. The other thing that we need to think a little bit about is not just about the family and about the siblings and about the parents, but these children will come back into services, other services. I suppose the difference between injuries that are sustained in childhood and injuries that are sustained in adulthood is that in childhood there is a statutory service that all children have the right to access, and that's education. In adulthood there isn't quite the same arrangement in place. And what happens there is then, or the implication that that has is that the people who we then ask to manage and assist our children following on from these types of brain injuries, they themselves need to understand what is it that they are working with, how is it that they can help. And this, I suppose, was brought home. There was independent research done through Queen's University Belfast, published back in 2013, looking at educational professionals' understanding of childhood traumatic brain injury specifically. And one of the observations that they made was that clearly more work must be undertaken to raise the profile of pediatric brain injury among educators and increase the understanding of its consequences, both in general and in relation to educational outcomes. I would caution that we're not just talking about education here. I suppose the international research would say that even within pediatric services, there can sometimes be misapprehensions, misunderstandings of the longer term implications of acquired brain injury in childhood. I suppose one of the ways that came home to me in a very real way was in the conversation that I was a party to between two social workers, one of whom looked after children's services, who noted on the basis of whatever the discussion was, that she had never realized that following on from a baby having been shaken, that the child could have actually sustained a brain injury in the course of that injury. Now, to me, traumatic brain injury in shaken babies is a very, very real possibility, and is actually possibly one of the most challenging types of injuries that can be sustained, partly because of all the other things that go on with it as well. But it brought home to me the need that service providers across sectors and across divisions of how we see our services right now need to have this idea of a shared understanding, a shared way of thinking about these children. It was interesting as well once when doing a course up in Stranmillis for special educational needs coordinators, and at the end of the course a Senko came up to me and said that was really, really interesting. After 20 years of teaching, it's really been helpful to actually understand in what way brains actually work. Now, to me, that was always quite surprising, because educators and teachers do have a huge understanding of how brains work. But other research that we have done, looking at teachers' experiences of teaching children with acquired brain injuries, has actually borne out the fact that actually, if you don't have a huge understanding of the types of difficulties that the child in front of you might actually have, it can be a quite difficult experience not being able to progress with their education in the way that you anticipate you should be able to. And teachers certainly talked about how there was an emotional toll for them in not being able to educate the child, a specific child. This was research with teachers who had taught children with brain injuries. It was really important that we were able to acknowledge and recognize and support those teachers who are trying to do their very best to educate these children. I suppose if I take a step back to the very earliest stages of my own kind of psychology career, one of the most influential things that I ever came across was a model called Yuri Brenner's ecological model of human development. And Brenner's model talks about how children develop on the basis of the interactions that they have with those people who are around them. And for that reason, it's important that there is a kind of an understanding, an acceptance and empathy, a connection between the child and their caregivers, but also service providers. And I suppose one of the things that's actually been that I'm really delighted about in relation to this conference and what we're going to be talking about over the course of the day is the fact that within today we've got representation from a significant number of the various areas that are talked about in this model. So obviously we've got the child at the center, or a young person in this case. We've got people who are experts by experience who will be talking to us later on today. But we also have representations from the immediate family, from childcare and education, from those people in the community healthcare services as well, who are providing that support. But we also have, obviously with Minister Swann here as well, we've got the representation from the kind of the outside level of the model, the legal and legislative frameworks that actually inform how our services are developing. And with that in mind, I'm actually really delighted that as we talk through today, I think we're going to be able to see how there has, within this particular population, within this particular service area, that there has been progress towards what has been inspired towards for quite some time within Northern Ireland health and social care services. Back in June 2016, Janice Thompson at the Northern Ireland Assembly talked about how the health and social care system needs to continue to work in partnership across government, with industry, academia, the community and voluntary sector, staff and patients to develop new models of care. And it really is a helpful idea and a helpful prospect that as we talk through today, I think we will be able to see that there has been progress made in this relationship. There are still challenges and there is still work to be done. But I do think that we can be quite proud of how far we have come in regards to developing these services and working collectively with a shared understanding to do better for children and young people who have acquired brain injuries. Thank you.
Thank you very much, Eunan, and thank you for a really insightful and very, very challenging presentation. I was just struck, Eunan, in your presentation around the issue around I suppose the clinical challenges in diagnosing and treating children and young people with acquired brain injury, and from that the theme of partnership, which you alluded to as well, and clearly there's a range of players involved in that treatment and development. I was wondering, just picking up a couple of things you said. I mean, clearly the family are at the centre of this, and for a family whose child has been diagnosed with an ABI, I just wondered, from your experience and perspective, how difficult or easy it is for a family to negotiate the pathway for a child that has ABI and the range of supports. I wonder, sometimes are parents and families confused as to what's available, or do you feel the pathways are fairly clear cut?
I think, Joe, it kind of goes back a little bit to what I mentioned earlier on in terms of the variety of ways in which brain injuries can be sustained. I think for certain populations, there is maybe a somewhat clearer pathway, partly because there maybe is a kind of a more developed team around those children, or those medical and acute management specialisms within the hospital services. I still think, whenever parents and children, sometimes parents and children can spend months in the hospital before they can be discharged. Other children actually have a relatively short kind of course there. So I think you're still talking at quite a variable experience of coming through services. I think the issues can sometimes come up where there's that interface between either kind of health and education, or between even acute and community services. I think that's where there needs to be a kind of maybe a simplification. Certainly, I think clinicians at an individual level do their very best to assist families in understanding who they need to talk to, or who might be an important person to have to assist them with the difficulties. But I think it is quite a variable experience, partly associated with the type of injury that was sustained in the first place. Okay, thanks, Yunan. And just picking up, I suppose the other question I had was the challenge to families, and we mentioned the sort of the paediatric and psychological services available for children. Do you feel that those services are available
as and when they're required, or are there still challenges in accessing the services?
I think that's a good question, Joe. I think sometimes there can be issues in relation to, in psychological therapy, we often talk about, about whether or not this is the right time to be offering an intervention. And it's sometimes the case. I actually remember very clearly, it was actually one of the parents who was in the Talking Heads group talking about how, I think they were quite proactively followed up from the point of actually leaving hospital. And for the first 2 to 3 weeks, they kind of had weekly checks through the health service, and they felt that was really helpful. And then they were kind of signed off and left. Now they were told how they could re-access services, but I think their reflection, I think it was probably even years down the line, was actually, do you know what, we didn't know what we needed until later on down the line, and it was only then that sometimes they struggled to actually be able to go back and get it. So yes, I think there can still be issues sometimes, but I think that's actually where organizations like Brain Injury Matters are actually really, really helpful, because when the parent is able to raise that question, it can be directed into somewhere like Brain Injuries Matters, and because of the way in which that partnership exists between them and somebody like Belfast Trust, there can be a clarification coming back relatively quickly to say, this is the easiest way to do this, this is the most expedient way to do this, this is who to talk to. So I think that's where the value of the partnership working comes in. I think, yes, there can be issues, but I think having that partnership there kind of facilitates the process to make it a little bit easier for people coming back in again.
Okay, lovely. Thank you. Just one final question, if I may, and conscious of your time. And the Minister referred to the sort of rebuild agenda, and not wishing to put you on the spot, but if you had a magic wand and limitless amounts of money, how would you like to see the services developing over the next 5 years? Well,
I think there's been a couple of references already to the fact that there is a kind of a difference between, or there's a lack of that type of a dedicated rehabilitation service available to children that is kind of post-acute, so after they've actually left hospital. So I think a service like that, which would allow for there to be a kind of an understanding and allow for there to be maybe a contact point for an awful lot of the information that is needed, because these children will often, especially those children with more severe injuries, they will have needs that are maybe physical, maybe communicative, cognitive, and maybe in some cases behavioral and kind of emotional and adjustment related. So I think having something that is more integrated to allow that to be actually held in one place and then feed into the local services that are available, I think that would be particularly helpful. And that's what I think is the aspiration. I think it's one of the things that the Minister has made reference to himself in some of his speeches as well. So I think that would be, I would be very happy to see that happening in the next 5 years.
That's great, Eunan. Not to put you in the spot, obviously, but thank you for that very honest answer. Eunan, that brings us to the end to your slot this morning. I hope you can stay with us for as much as you can of the day, but it's been a real pleasure, and thank you very much for a really interesting and challenging presentation. Thank you, Eunan. So I'm in the spirit of partnership, I'm going to pass on to our next speakers this morning from the Children's ABC Services, Dr. Katie Burns and Charis Wylie. Katie and Charis are going to tell us a bit more about the services they provide, how that fits into the jigsaw of services being provided across Northern Ireland, and talk a wee bit more about their plans post-COVID. So I'm going to pass over to Katie and Charis. Thank you very much, Katie.
Thank you, Joe.
Yeah, thank you, Joe. And good morning, everybody. It's lovely to be with you, and it's great to have the opportunity to speak to you about our service. My name is Charis Wylie. I'm a speech therapist. I'm here with my colleague Katie Burns, who's a clinical psychologist. We both work for the Children's Acquired Brain Injury Consultation Service, which I'll be referring to as the CABCs, as it's a bit of a mouthful. The CABCs is based at the Children's Hospital at the Royal, and Katie and I spend part of our working week with the CABCs, but we also input into work in the hospital, seeing children as inpatients. And our aim this morning is to highlight the work of the CABCs, explain how it interfaces with other services that support children with a brain injury and their families, and discuss the goals for service development post-pandemic. In many areas, the health and social care sector faces the challenge of meeting significant need for services out of a limited resource. This challenge is typical in the field of acquired brain injury. Children, young people and their families living with acquired brain injury regularly access a range of local services, for example, health, social services, education. These services may have limited specialist knowledge or skills in the management of acquired brain injury, yet have the capacity to be upskilled in the knowledge, skills and core competencies to support these children and young people. A specialist regional training and liaison service was considered necessary to provide the consultative link and bridge that gap for local services in order to ensure good practice for these children and young people. And there's a wee picture of me and Katie bridging the gap.
Who's who? Who's dragging who down?
That was pre-pandemic. As a result of a review of services for children and young people after an acquired brain injury by the Regional Acquired Brain Injury Implementation Group, referred to as RUBIG, in 2011, Northern Ireland's Health and Social Care Board established our specialist service, the Children's Acquired Brain Injury Consultation Service, the CABCs, in 2012. The RUBIG review identified inequalities between adult and children's services, a perceived skills gap in managing children and young people with an ABI, a lack of information, and a need for transition arrangements. In their 2015 research into children and young people with ABI, Angela Chicha and Travis Stretz highlighted the need for multidisciplinary input with this client group. Addressing contextual factors is a complex undertaking requiring a multidisciplinary approach from clinicians. As such, the CABCs incorporate specialist skills from clinical psychology, occupational therapy, and speech and language therapy. And the three of us spend part of our working week in the CABC service. And collectively, our time allocation equates to one full-time equivalent. Our service is regional, covering all health trusts, any school in Northern Ireland, and all voluntary sector services. The remit of the CABCs is to build confidence and competence of staff working with children and young people with an acquired brain injury. The CABCs has delivered its brief primarily through consulting with existing services regarding individual children in their care, and by training a range of service providers in the area of acquired brain injury. So as such, the CABCs offers training including generalised undergraduate and postgraduate training, training to voluntary services, as well as child-specific school training. We signpost to information resources and voluntary support agencies. Through consultations, we can offer child-specific advice and support to statutory and non-statutory organisations, for example, CAM staff and teachers. We offer the opportunity for joint working with external agencies such as schools or voluntary services, and we offer specialised professional support in the areas of clinical psychology, occupational therapy and speech and language therapy. The CABCs is involved in providing consultations to a range of service providers, and this graph shows the breakdown of services which sought consultations in the last 2 years. So as you can see, the largest number of consultation requests came from within education, then health, and then the voluntary sector. I really wanted to take time this morning to give you a sense of what consultations look like to help you better connect and understand our role. So with that in mind, we've prepared a few case examples which I'll talk through now. The first case here is child A. He was 4 years and 10 months old when he had a posterior fossa tumour resected. At the time of consultation, he was just over 6.5 years old. The referral came from the local occupational therapist who described issues with fine motor delay, coordination and balance, as well as variable abilities to complete daily living skills. I realise that there's a lot of acronyms in our presentation, and we've got a little glossary list at the end in case you miss any of it. Child A presented with poor eye contact and limited verbal responses. He had been discharged from local speech and language therapy services without being seen, as his family hadn't responded to appointment letters. and he had been unable to attend paediatric psychology appointments. At the point of consultation towards the end of last year, he had not returned to school since having neurosurgery due to family concerns about infections of neurodermatitis and COVID-19. A statement of special educational needs was initiated, but it was unclear how far this had progressed. He was not involved with home tuition from the Education Authority at that point. He has 2 older siblings, one of whom has a diagnosed learning disability and significant caring needs. As part of our consultation, we ask each referrer to indicate what they hope to achieve from a consultation with our service. And Child A's occupational therapist identified that she wanted to consider ways to promote a safe return to school following this extended period at home. During the consultation, we spent time asking questions to better understand the situation and then problem solving the child's return to school and engaging and difficulties engaging in other services. So we discussed ways to support the child's family to attend the services he was currently involved with before offering additional services. We highlighted the benefits of a speech and language therapy assessment for a review of the child's language, communication and feeding skills, as that's what had been initially, that's why he'd been initially referred to speech therapy. We discussed how the occupational therapist could support his mum to use an activity schedule to structure her son's day at home. We suggested a referral to Brain Injury Matters Family First Service for support for the whole family, as well as the child individually. We advised that the school involved can request a consultation from our service if they have specific queries about how to best support this child's return to school. And we advised the referring occupational therapist that the school should liaise with the Education Authority in order to initiate home tuition. Our next case example is of a child B who was 14 years old and had a hypoxic brain injury earlier that same year. This referral came from her school, who reported difficulties with fatigue, short-term memory, and low scores on cognitive assessments. The school wanted advice on how they could support the child's development and recovery. Again, we spent time asking questions about how the child was doing in school and teasing out some of the issues. As part of this conversation, we talked about the challenges of following a full GCSE timetable and felt that it was important for the school to have conversations with the child about her hopes and goals for education and career. Cognitive assessment had been completed by this stage, but the findings weren't available during the consultation. So we advised that a review of this assessment would be beneficial to really understand the child's cognitive skills, which may have been impacted by her acquired brain injury, and how to best support her now. We suggested that speech and language therapy assessment would be helpful to look at her language and communication skills to inform how to best present information and support her learning. We proposed the use of movement breaks to address some of her fatigue, and we recommended family support such as counselling through the Child Brain Injury Trust. Our final case example is about child C, who is now 7 years old and presented with seizures and developmental regression at 11 months old. An MRI of his brain showed abnormal calcification in the parasagittal area, suggestive of a previous problem with blood supply. Difficulties were becoming more apparent over time, and child C was not achieving academically. This referral came from his school, who noted that the child required instructions to be broken down and repeated, that he had difficulty retaining information, and that he played alongside rather than with other children. Child C had been seen by the educational psychologist, who reported a marked impairment with processing speed and working memory. This child had some insight into his difficulties, which could result in frustration, holding his head and covering his ears. The school also commented that he fatigued during the day and is sometimes tearful. And his school were really keen to explore ways in which they could assist him in his learning. During our consultation, we discussed a psychology assessment of the child's cognitive profile to better understand his cognitive skills. We talked about using the method of errorless learning when teaching to help address memory issues. We encouraged school staff that repeating information and using visual supports are helpful in supporting the child's understanding of language. We recommended occupational therapy assessment to look at a sensory profile and fatigue management. We also recommended a speech and language therapy referral for language and communication assessment. We then talked about a potential referral to the Regional Integrated Support for Education in Northern Ireland Service, which supports children in preschool, educational and mainstream primary school settings. As we felt Child C would benefit from an OT and speech therapy assessment, the school could consider a referral to this RISE NI service. And finally, we encouraged a referral for the parents to Brain Injury Matters for family-focused support and to help them understand Child C's specific difficulties. Hopefully these case examples have given you a sense of our work in consultations, where we are upskilling staff already working with children and young people with an acquired brain injury, and increasing staff confidence in offering ABI-specific interventions. Through consultations, we are able to raise awareness of acquired brain injury issues, increase knowledge of available support services, and improve the quality of care received by children in Northern Ireland who have experienced an ABI. I'll now hand over to my colleague Katie to continue our presentation.
Thanks, Chris. Okay, I'll probably start by making an apology in advance. The office I'm in is very kind of eco-friendly, and as such, if I don't move for a period of time, the lights go out. And if I'm facing the computer talking to you, there's a high chance that will happen by the end of the presentation. And I'm going to attempt to just move up gradually to prevent that from happening. If it does, it's fine. You'll see me flailing about. I'll continue to talk, and we should never speak of it again. Okay, so as Charis explained earlier, whenever we set up the consultations or invite people to be part of consultations, what we do is we ask them what their specific questions are. So it's really just, we discuss whatever they want to bring. And as such, that can be very varied, as you'd expect. Over time, we've noticed that a few common themes have come out. So we've kind of pulled them together just to look at today. I don't want to go into these in a lot of detail, not least because everybody here, I'm sure, has an awareness of some of these difficulties because you're curious, you're interested in acquired brain injury, and also because you touched on that in a lot more detail in his presentation. So in some ways, it's great we're following him, because lots of the things that are on this slide, he's already talked about. So yes, what comes up a lot is how we support children to access the curriculum, whether that's by way of how we transition someone back into school after a period being off, or how we might respond to some emerging evidence of perhaps not attaining to the best of their ability. We spend a bit of time talking about challenging behaviour. This might be something that's evidenced in the home setting or in schools. And really what we try to do is encourage the referrer to kind of view challenging behaviour as it means the child's communicating a particular need, whether that be sort of they're quite sort of their integration isn't as good as it used to be, quite overwhelmed, and they might need some of that kind of sensory information kind of just or removed, or whether they're kind of feeling anxious and need a bit of support or comfort just to kind of help with regulation. Really what we do is we find that people kind of want to talk about behaviour, and we do provide strategies in managing behaviour, but we would also really encourage someone to kind of sort of reflect on what might be behind that and whether there's other things going in the environment that might warrant a bit of change. We often talk about peer and social difficulties. This is something that we find that young people with an acquired brain injury may struggle a bit more with, whether that's because they've spent some time out of school or they can't attend activities and they're missing opportunities for peer engagement, or whether or not there's maybe kind of sensory or some processing difficulties that mean that social interactions are sort of more difficult to understand now. We might kind of give some thought to how an assessment might pick that apart. And once you're kind of clear on what the difficulties are, how you might sort of support or intervene. We talk about participation in meaningful activities, and it's something that comes out naturally. We know there's a huge mental health benefit to any and all of us sort of participating in meaningful activities, and these are very individual. It could be sport, it could be dance, it could be just losing yourself in a really good book. And we know that after an acquired brain injury, some of the difficulties that children experience mean that participation in these activities becomes more challenging, and that could potentially have an impact on their emotional well-being. So what we might do is have conversations around how we either reintegrate them back into meaningful activity, or how we acknowledge that that's maybe not possible, and how we sort of seek out new meaningful activities or find adaptations that can happen. And I suppose what's really important is I find that these common themes come through. We think that's important because it gives us the opportunity then to take these and kind of weave them into the training that we do. So we recognise if these things come up again and again, we need to think about how we get the information out there, or how we kind of get the way of reflecting about things out there in a different way. So certainly, as we've had consultations, our training has changed very slightly to ensure that we're capturing some of this in what we do. And as like the rest of Northern Ireland, the rest of the world, probably in the last year, we switched to doing things kind of sort of online, virtually. Our way of collecting feedback about things was no different. So we switched from using paper forms, which kind of predated my time in CABCs. We tried kind of do a form that people could fill in online. Had a kind of small number of consultations and an even smaller number of returns. So I'm very aware that we can't really extrapolate from the data that we have. And we kind of reconsidered putting this in, but I think it's useful to kind of think about today, just for our own learning. Because what we actually saw from that is asking questions around, do you anticipate the practice change on the basis of a consultation, or did you find professional beliefs challenged or changed today? Some people were saying a great deal, some people saying a little, but actually, someone was saying not at all, and that was quite a surprise to us, because for us the feedback that we get at consultations was so positive. So it kind of felt, have we missed something? Or people just not able to tell us that it's not working and this is capturing what it really is? But we'd included a qualitative bit in the form, and I suppose that really kind of helped put it all into context, because the qualitative information, as you can see here, my answers to these questions are not particularly positive to the service, do not do the service justice. We're a service that work directly with children and young people with ABI already. They have a lot of skill knowledge. So I guess Charis and I were coming into this on the therapist heads on, thinking about what are the sorts of questions that we ask to find out if something's working, and recognising asking these sorts of questions in the setting doesn't really work. It's not that everybody is looking to sort of plug a skills gap here, and actually what CABCs do for some people is kind of add something more than the knowledge, kind of add a space for reflection, maybe add some specialist speech and language knowledge or specialist psychology knowledge that somebody is seeking. So really it's kind of been a lesson for us, and I'm glad we looked at data quite early on, because we probably need to go back and look at our form again to ensure that we're really capturing the information that we need to, because nobody wants to undersell what they do. We also run kind of regular training programs. So there's a rolling program with the Clinical Education Centre, which coordinates and delivers training to kind of healthcare professionals in Northern Ireland. And we have a 2-day acquired brain injury and childhood course, and we have a 1-day course in acquired brain injury in adolescents. Both of those will cover the background, so kind of the neuroanatomy, what kind of happens in acquired brain injury, what are the impacts that you might see. The adolescent one kind of goes a bit further in and looks at some of the neuroscience of kind of the typically developing teenage brain. And it's kind of really interesting because it allows us to compare what some of the kind of normal, typical developmental sort of activities might look like, and how some of those sort of mirror an acquired brain injury. And we talk a little bit then about how you might tease that apart, how you might fully understand what's development and what is the acquired brain injury. So it's a really enjoyable course to run, and I can hope people that find it as enjoyable as we do to administer. We have training with Queen's School of Medicine in the long-term sequelae of meningitis. We feed into the Queen's Educational Ecology programme, the DCAP programme, and provide sort of an ongoing over the course of the year some input into, again, understanding acquired brain injury, some of the impacts you might see, how you might identify and recognise that, and from a psychological perspective, how your assessment might need to take account of kind of a number of different things. And we also run similar training with the Queen's clinical psychology course. And as our Minister spoke about earlier, there's a relatively new collaboration with the EA. So the CABC service in conjunction with Educational Psychology are running a new course for SYNCOs on acquired brain injury. And to me that's very exciting, because it begins to kind of plug the gap that we've identified, whereby there's been that lack of collaborative input between health and education in terms of how manage kind of the longer term experience of an acquired brain injury in school. And for me, something I feel really strongly about, it's so important. So if you think about it, children spend kind of 5 to 6 hours in school a day. It's 5 days a week. It makes up a huge part of their waking life. And if things aren't going well, and if school doesn't feel like kind of a safe place to be, then that's very likely to have quite a significant impact on other areas of their life too. So we really want to get that right. We really want to identify difficulties early and get in there so that children don't have that difficult experience. And we also do bespoke training events as well. So that's on request. The ones that we've run recently have been about understanding kind of mood difficulties following an acquired brain injury. And our OT did some training in airless learning and neuro rehab. So that's the kind of thing that we'll do. If you have a particular thing that you want to find out more about, you're more than welcome to come and chat to us to see what we can offer. And this slide here just kind of gives a bit of a summary about who has been seeking training from CABCs. And if you think back to Charis' side, this is almost a reversal. So whereas before there's more kind of people in education seeking consultations and for your in health, here we're seeing that more people in health are seeking training from us. And I suspect that that's very much down to the fact that the CEC run the programme. It's been around for a while. There's a lot more awareness about it. And that's why we tend to see more requests from training from sort of the health sector. I'm hoping that over time, as awareness about the kind of Synco training grows, that we might see more requests from education and a bit more of a balance. So some feedback from training that we've had has been really positive. So people like, and this is all the virtual training that we've done, so people acknowledging that it's been sort of well prepared and adequate. And I suppose that's really heartening for us because it kind of hit us and we felt like we had to adapt things very, very quickly. And I suppose we were kind of very cautious about running it just in case people didn't have the same experiences they did when it was delivered face to face. So it's really nice to know that people are experiencing that as good quality training. That it was informative, even with the new format over Zoom. Presenters made it interactive and engaging. The topics provided with insight and allowed discussion and tailored learning to the audience's needs. And again, that's really to hear because when we have 2-day training in AB in childhood and only 1 day in ABI and adolescence, for example, sometimes it feels like you don't have the time to do everything that you want, and it's very hard to get the balance right between giving lots of information versus given enough time for discussion. And it's good to know that some people feel that we've got it right. And then just to add a bit of balance, you know, we do get some not positive feedback sometimes. It's mostly just around kind of Zoom and how tiring that is and the technology, and also kind of 1 or 2 people feeling that breakout discussions are less useful as the input from the experts. So that's when we invite people along from services or from our colleagues in Brain Injury Matters and CBIT, for example, and we're hearing that people really enjoy that and would love more of that. And if you'll permit me to be a little bit indulgent, I suppose I wanted to share this because it's a piece of feedback that I really appreciated. Really, I think about it a lot, and I'll explain why shortly. It's feedback that came as a letter following the recent virtual training to Queen's medical students on meningitis. And the course director said at the final assessment, several students chose to focus on the multidisciplinary team and long-term complications, which shows that you definitely caught their attention. At the informal feedback session, they commented that they rarely get the perspective of other health professionals and they really value this. And I suppose that was lovely feedback for us because you know, we acknowledge that a lot of the other training that we do is healthcare professionals or education professionals with an interest who are seeking out information, and it's lovely to have the discussions and do the training that we do with those. This was training where it was part of a much broader course. Nobody had invited it, nobody had specifically requested it, they were there quite passively. To know that actually then someone went on and had listened and actually chosen that as their exam question, which was, if done exams, kind of, you know how big that is. And I suppose for me, it just really lifted me to know that our children with an ABI, the children that we work with, obviously they come through specialist ABI services, they come through services where people are well equipped to deal with ABI, but they also go through lots of non-ABI services too, and have contact with lots of sort of services and sectors where people don't know a lot about it. And it's really heartening to know that kind of in a few years, there are people out there in non-ABI services who potentially won't know enough to be curious, to ask questions, and hopefully signpost people on to the services that they really need to be in. So that's why that kind of has really stuck with me. If we have time, I think we have a few minutes. It would be nice to kind of share a few of our own reflections, the conversations that we have behind closed doors, just based on our learnings. So for those of you who know Charis and I, you'll know as well as being members of the CABC service, also clinicians who work in the neurology team in the Royal Belfast Hospital for Sick Children. For me, it's a real privilege to have that split post. It is, of course, very challenging, but there's just something so lovely about being able to work at the acute side of things, but then also have conversations about children and families much later on and get a real sense of the things that actually are a problem later on, because for us then it helps shape the work that we do at the acute side. It's almost like we're in partnership with ourselves. And some of the things that come for us is maybe that this first one, I don't think that we have it quite right in terms of getting addressing what families need. And so I think we hear conversations that let us know there's a bit of an issue with timing of support. So maybe things have been offered at a point of crisis where a family has declined because they don't feel in the right place to use it, and then it doesn't get offered again later on. Or there's families who perhaps get what they need within special services, but once they're discharged from that, may have a bit of difficulty accessing that elsewhere. And certainly from a therapist point of view, I know I've had experience of perhaps not having the ending that I want with families, or the end that I think is good for that point in time, because they're very understandably worried about being discharged, because they recognise that it might be difficult to this a bit later on. So I definitely think there's more that we could do collaboratively, talking together about how we sort of support families to get the right service at the right time, and that they don't need to kind of have to battle to get that later. So thinking about who and what needs to change, sort of the child and family versus society. So as therapists, we work individually with children, families, potentially kind of schools and other services. Within CABCs, so we have conversations with other services, but certainly it rarely goes more broadly than that. And if we think back to Eunan's discussion where he was talking about Brenner's model and those systems around a child and that's ever widening, I think that maps really, really well onto the ideas that I have around that. So I mean, it's undeniable that society is organised sort of around non-disabled people. And there's an expectation that others kind of with a disability or some kind of neurological difficulty need to fit in around that. So they need to ask for accommodations. Things sort of have to be changed slightly for them. And I think we need to give more thought to how, whenever we are setting things up from the get-go, how we work with kind of justice, how we work with the infrastructure, just to ensure that we're kind of embedding those ideas right at the beginning, and actually kind of shaping services for people with disability aren't an afterthought. And then this idea maybe of COVID-19 is leveling the playing field. I know when the pandemic hit, I was like most Christians really quite concerned about what the impact might be on our sort of children with an acquired brain injury and their families. And certainly that has been difficult. So kind of whenever Robin talked earlier about how sort of services were suspended, sort of respite kind of wasn't available, and that placed more of a challenge on families. But there was things that kind of went out well too. So, children who were used to kind of spending time out of school, everybody was out of school, everyone was at home, everyone was doing things online, so activities could be done online, and physical access isn't so much of an issue. And for children who really rely on parents as opposed to recognise their needs and be the conduit to explain that to other people, and families were spending huge amounts of time together. So for some families, things actually muddled along quite nicely, and the challenge that we might have anticipated didn't happen. But certainly, anecdotally, what we're hearing now in conversations in CABCs is actually once children are returning to school time, there's a bit more difficulty, a bit more of a challenge. So it kind of leads us to think about what we need to do in order to, I suppose, help services prepare for the potential difficulties that we might face over the kind of the coming sort of weeks, months, and potentially years. I'm aware I'm very short in time and possibly over. I'm surprised Joe hasn't kind of come on to wrestle control off me. Thanks, Joe. Our final slide here just talks to me about future directions. So it's just Charis and I, we're missing our OT. She's off on maternity leave. So realistically, we've just thought about how we can keep the service going and how we can do as much as we can in the interim, with very much an idea on how we can kind of improve and push us forward when we're back to our full staff complement. One of the things would be profession-specific training. So when we do our generic training, we often have questions about how that might work within their own kind of discipline, how that might work in terms of a particular intervention, and we often don't have time or scope to be able to talk about that. So really what we want to do is think of how we just offer them profession-specific training to allow us to really dig down and answer the questions that people want to know. Virtual consultations, it was an adaptation. We want to do it during COVID just because we had no other choice, but actually it's worked incredibly well, and the consultations kind of flow really nicely this way, and we save a lot of time because we're not driving around. So I imagine virtual consultations are something that's here to stay for us because they work so well. In terms of networking, so I mean, essentially what this day is all about is about the partnerships. It's about networking. For us, we've just spent the kind of the first year in post really just setting up our own networks with people. More recently, we've maybe had conversations or had requests that allow us to kind of see a role in us being able to facilitate networks between other people. That's maybe where we kind of look to kind of focus our energies in the future for that. And also then just COVID and moving into kind of virtual world and technology, I suppose, kind of pushed us down a road that certainly at my age I wasn't overly comfortable with, but now that I'm here, I realise the value of it. I suspect there's kind of a much greater use of digital technology that we could be using, and I think something like podcasts would work really well for our service because it's all about conversations. It's about just giving information, and we know that there's common themes that come up. So it's there's the potential for us to kind of maybe sit down and do a series of podcasts on topics about brain injury that people are keen to hear about. So how to access the service? We have referral forms. You could email the service. We send anything out that you need. The email's included in here. Also, there is information on the service and referral forms on that web link for Belfast Trust. There's also one for Northern Trust as well. And certainly that doesn't speak to any particular relationship that we have because it's a regional service. It's just that some IT services have been more responsive. So if you look on the Belfast Trust side or Northern Trust, you should be able to find a bit more information about us. And we're really happy just to kind of field a call or an email or whatever it takes just to let you know a bit more about us.
Lovely. Katie, thank you. And Charis, that was really interesting, and apologies for popping up. Obviously, time's always a pressure in these conferences.
Absolutely.
But anyway,
thank you, Joe.
Not at all. It was a pleasure. I'm disappointed I didn't get you to see flailing about. I've always wanted to see a psychologist flailing about in the event of your lights going out. But it was great.
I'm clearly more active today than I'd given myself credit for.
Oh dear. Well, look, in the time we have available, I just wanted to maybe pose a couple of questions, and there was a very specific one from Anil Sharma, which again, I'll maybe get Anil to follow up directly. It was around recommending particular training courses for those working in the community may want to offer. They're doing health and safety courses, but they wanted to maybe get advice on other courses that might be helpful. Secondly, a question around the role of parents in informing the training that you offer. And I suppose my third question is more of an observation, and go back to Charis's first slide where two of you were acting as the bridge across a very deep hole, I imagine. Your own demands and workload, because I'm mindful of the fact that you're a small team, albeit very much around a multidisciplinary team, but how do you cope with the demands? So question around the input of parents into your training, how do you cope with the workload? And also maybe just commenting on, and you referred to it yourself, the importance of taking a multidisciplinary approach. So I have 2 minutes to get you to respond to 3 questions. Thank you both. I'm not sure who wants to start. Charis, Katie?
It's hard to, I'm feeling a bit under pressure with 2 minutes, but I suppose in thinking about how parents inform our training, with both of us working in the hospital, I think we've seen and experienced like some of what the families go through. I think that will always stick with me in terms of the family experience, just what I have seen firsthand in the acute side of things, and then following some people through to when they're back out and at home again. So I think like that has changed me and how I think about how I talk to the families. I'm so careful about the words that I use. I think like how we communicate with them and how we explain what's happening is so important. So we do spend time talking about the emotional impact of what's happening with these families and being mindful of that, and then also how careful we are about how we communicate with them. We also do in one of our trainings have a video of the family of parents sharing their experience, which is so powerful for the attendees just to really hear the parent and family experience. So it's like I said, it's a really powerful moment. Katie, is there anything else you want to add?
No, I think that's it. I mean, I think it just kind of speaks so much to the idea that you know, we bring so much of the other part of ourselves into the work. So certainly how I deliver the training, things that I included in training are very much informed by what I hear as a clinician from families. And that's the information that I want to share. And then vice versa, so I'm hearing things I then want to kind of take back into my clinical work. So there is that just kind of that connection I think is really helpful. Yeah. And Joe,
sorry,
asked,
not sure we've answered all three of your questions there, sorry.
No,
Joe, you'd asked a little about, sorry, I might be interrupting there, but you'd asked just kind of about the balance and the challenge. I think I spoke a little about that in my presentation. Split posts, they can be challenging. I suppose for us it has just been about being quite boundaried with our times, sort of having particular days for particular things. And really trying to utilise the partnerships that we have. So coming into post, we had people around us who had more experience, who were able to kind of guide and support us, and we sort of asked questions and we took advice. And obviously kind of we called on yourselves and kind of and the guys in CBIT just kind of help sort of guide us in terms of what was needed. And as well as that, then just trying to think creatively about what we do. So you know, what do we do that's maybe less effective, or what can we change? So for me, the idea of something podcast really just kind of pays note to the fact that if we keep continuing to do things the way we've always done, eventually that becomes like less successful, or it becomes unhelpful. So always thinking about what can we do, how can we still kind of meet a need and do that a bit more creatively.
Okay, lovely, Katie, thank you. And maybe just a final question for those who aren't maybe that familiar with your service about your position, or do you have the authority to make referrals to other services?
No, we don't. Essentially what we would ask the referrer to do is either kind of make that, if they're in a position to liaise with the family, just to, you know, flag up that's been identified as potentially being helpful, because we don't have contact with families. And obviously to make a referral, we would need to have some consent and things. So because we don't have that contact, we're not in a good position to make referrals. It really just is about identifying and signposting. Okay, and again, I suppose that's emphasising the importance of the partnerships and the relationships with the voluntary and other partners as well within the statutory side.
Yeah, that's right.
Okay,
lovely. Well, look, first of all, can I say thank you both for your really interesting presentation and very comprehensive, and apologies for the time pressures, but it's been great to see you both, and I hope you're able to stay with us for the rest of the morning as much as you can. Thank you. You're very welcome. Thank you so much for asking me to be part of today, Joe. It's been great. Thank you. And thank you, Charis, as well. Good to see you. Thank you very much. Okay, well, we're going to move on then in this spirit of partnership to the next partner in terms of the jigsaw of delivery and services within Northern Ireland, and that's moving across to the Education Authority. The Minister, Eunan, and Katie have referenced the work with the Educational Psychology team within the Education Authority, and it's my pleasure this morning to welcome Ruth Nesbitt and Dr. Martin McKeever. I would say before the presentation starts, we have 113 people on our call today, which is absolutely fantastic. I'm not sure whether it's Monday morning or people are very shy, but feel free to ask questions, and we'll try and get back to you as much as we can and cover them in the time we have available. But as I say, I'm just going to hand over to Ruth and Maria. Thank you very much.
Morning, everyone. My name is Dr. Ruth Nesbitt. I work as an educational psychologist for the Education Authority. and I'm joined today with my colleague, Dr. Maria Martin-McKeever. We have both been working on a pilot project to deliver ABI training within schools. These are some of the things we're just going to touch through today. So we're going to just talk about how the Educational Psychology Service is currently working in Northern Ireland. And a theme for today that's already been really clearly established is that need for partnership between the healthcare service and the education services, both in terms of schools directly, but also the wider education services that can support schools too. We're going to talk through our pilot ABI training that we are delivering to schools currently, just how that came about and what content we felt was really important to include in that. And we've had some feedback from that, so we're going to talk through how we're going to use that just to inform how we want to extend our training over the next academic year. So currently the Educational Psychology Service offers quite a range of services to children, to families and to schools. So this can be done directly supporting school staff through consultation, through talking through practical advice and strategies that they can use to support their school population, or on a kind of broader scale to offer whole school training on certain topics that are relevant for that school. Input can also then be focused to the individual children and young people through assessment or through intervention. And within the Education Authority, there are lots of other support services that can support children and young people in schools. And the Education Psychology Service works in collaboration with lots of these services. So there's lots of links there with other services that are supporting skills, which we feel is really useful going forward with our ABI training. As a service, we're always looking to see how we can meet the demands of those that we are working with. And that was essentially part of why this project got started, along with the children's ABCs. So when we're thinking of some of the ways that EPs are currently working and how we can link that with acquired brain injury, lots of our work is spent problem solving, and sometimes we don't always have the answer, but we are working with others to see how we can come up with those answers sometimes. Education psychologists work across every setting, whether that's preschool and nursery, primary, post-primary and special school settings. And we have a real experience of a range of special educational needs and other things that may be impacting a child's access to education and just managing day-to-day demands of a school environment. Educational psychologists are also part of critical incident response. So this can be when a traumatic event has happened involving a young person or a member of school staff or something that's really impactful to that school community. At times that can be in response to a traumatic brain injury. So EPs will have had experience of supporting schools in how to manage, both in terms of supporting the young person involved, but also supporting school staff. In lots of ways, our job does link with other health services, whether that's speech and language therapists, OTs, paediatricians. So some of those links are already there to facilitate that collaborative working. We'll talk a little bit in our presentation about the changing context of special educational needs from a statutory point of view and some new legislation that's going to be really important for schools to understand and how that fits, not just with ABI, but broadly supporting their children with special educational needs. And has just been touched on there, newly qualified education psychologists will have had some ABI training. So there's some skills there already within individual education psychologists and as our education psychology service broadly that we feel puts us in a good place to support schools in relation to ABI.
So there's already a range of current supports available to schools, as Ruth has alluded to. So all schools in Northern Ireland have access to the Educational Psychology Service. And again, as Ruth has already mentioned, educational psychologists have a wealth of skills and experience which they can bring to supporting schools and pupils who have acquired brain injuries. Outside of the Educational Psychology Service, much of the support offered to schools and pupils comes from the health and voluntary sector, and we very much recognise that. And I suppose what has been of interest to us in this journey of our collaborative working has been that, as Katie and Charis alluded to earlier, many of the referrals into the children's ABC service come from the education sector, despite there not being any representation from education within the current staffing team of children's ABCs. And I think that really shows the clear appetite for further support to schools in how best to manage those pupils and support the school as a whole. So I suppose, there really is this clear rationale for a partnership between health and education when it comes to supporting children and young people with acquired brain injuries. And we really need to ensure that there are joint and collaborative approaches to ensure the best support possible. So I suppose, why would this partnership work best, within the Educational Psychology Service and health as an initial partnership? The Educational Psychology Service consult with schools quite regularly, and we're directly involved with schools through our casework. So there is already that link established. And because we have contact with such a range of services in supporting the pupils that are referred in to ourselves, we are able, we already have a lot of those links formed, and it allows us to be that bridge then between education, health, and supporting the child. Our experience and job role and our training allows us to provide advice about special needs legislation, but also to inform discussion about medical issues that child may have and how that can create barriers or challenges within school. So kind of, bringing those different systems together. And it ensures that we are able to bring a better sort of shared knowledge base to increase access to services and resources, and to provide greater problem solving through discussion, which is informed by the experience of the different services involved and their practice, and just ensure really that we are more inclusive in meeting the needs of the child and their family following acquired brain injury, because we know that the difficulties that these children and young people can have following acquired brain injury, they spill across settings and across parts of their lives. So really, a collaborative partnership is the way forward. So we know from the acquired brain injury pathway document that it really outlines the key roles of educational staff and services in supporting children with acquired brain injury, and it indicates that need for collaborative and clear communication between health and education, really to ensure that information is readily available to all, and ultimately to support children with an acquired brain injury in their recovery and meeting their needs within the educational environment, and ensuring that information is carried across. So as I mentioned earlier, there are already a range of collaborative practices, and I know that Ruth mentioned this also. These links and relationships are established through a number of services, and these really enable services to work together to offer a better range of support to children and their families following an acquired brain injury. I've been fortunate enough, because I'm fairly recently qualified, to benefit from a lot of these collaborative practices, both in my training as an educational psychologist, where I had specific training from children's ABCs. I also was able to avail of an elective placement, and really within my job role, stepping in whenever so many of these collaborations were already set up, and these links already established, has made things a lot easier in my own practice. I know, and I'm sure Ruth is the same, just in terms of things being set up and established there. It allows that sharing of information to continue much easier. And I suppose, we were struck by this quote from some research that we read, which suggests really that educational staff very much value this collaborative support when it comes to supporting children with acquired brain injuries in school. And I think, part of the reason for that is because it is more of an unknown, and acquired brain injury isn't something that everyone's familiar with. And I know that Ruth is going to talk in more detail about the challenges for schools in facing this later in the presentation.
So I think we've been very clear, and other presenters today, that collaboration is really needed, and the word bridge seems to be coming up as the theme too. And I suppose when we were starting to think about how we wanted our training to be as effective as possible, these were some of the questions that we were asking ourselves. Do schools really know what their role is? And actually, do we as educational psychologists know what our role is? And through that discussion, we came across examples of when the educational psychologist was maybe informed of an ABI, not even using that terminology, but it was seen very much as a medical issue, and maybe something that schools wouldn't necessarily see a role for education psychologists. So that was just quite an interesting point of view that we were able to gather as a group together, and then thinking about some of those broader challenges then when schools are becoming maybe more aware of their role and how we can support with that moving forward. So we find that a lot of the terminology used can be quite difficult to get your head around if you're not used to that and kind of working within those services. And then knowing who to access for what kind of service, whether the child might need some OT or even home tuition. So whether that's a health trust service, social care service, or an education authority service too, as well as those voluntary organisations supporting families and young people. Schools, as been referenced before, is the second family. Children and young people spend so much of their time in schools, and schools really have that responsibility of supporting the individual pupil, but also all those systems around that pupil too. So whether that's their peer group, their family, their siblings, as well as actually supporting school staff. As we referenced before, through critical incident response, we know that sometimes the brain injury can actually have happened potentially on site or near school grounds, say if it's a road traffic accident. So schools are also dealing with their own personal emotion around that, as well as the very kind of traumatic and potentially distressing circumstances that have caused the ABI. Particularly now for schools, there is a lot of change around the new SEN Code of Practice, which we'll talk about in more detail, and distinguishing a child with special educational needs and a child with medical needs. And obviously there's some overlap too. And I suppose just in general, it's important to note the huge demand on time and resources that schools are currently facing and are increasingly facing, both in terms of managing children with special educational needs, but a variety of additional needs that, as I said, because children spend the majority of their week there outside of their family home, they really are that second family. And while that's a privilege, it's also a huge responsibility too. So these are things that have been kind of well noted in different parts of research, where there's maybe lack of training or lack of knowing where to source that training, a real kind of difficulty and disconnect between sharing information. That can be to do with confidentiality issues as well, or again, just not knowing who to contact to source that information, and really knowing how to manage ABI specifically to the child they are dealing with, and a real kind of tailored intervention and practical advice for schools just seems to be a wee bit lacking at the minute. In our training as well, we touch on whether the school staff are actually aware of the ABI. It may have happened during school holidays and then staff aren't informed or don't know, or it actually may have happened, say, in primary school years and the child is then in post-primary school. So there's lots of difficulties around ABI. It's a really complex topic and it can have a real kind of individual impact on different people. So again, just knowing how to source that information and really make it specific to the child the school is supporting. So we've talked about lots of challenges that schools are facing, and these are some of the big ones too. Really key, important legislation that outline the rules for schools. So we almost have two things going on. In one sense, putting schools forward as the people who have all these responsibilities and all these legislative demands, but at the same time acknowledging that there's lots of challenges that schools are facing.
So really in response to all of this, the clear need for further collaborative working in response to children with acquired brain injuries, a working group was set up on acquired brain injury and was established to develop training for schools. And has already been mentioned, this has been done as a partnership between the Children's ABC service and ourselves in the Educational Psychology service. This training is free, unlike some other training which has been offered previously. And I suppose with, as other people have talked about, it's moved virtual because of COVID, and there are some positives to that in that as those delivering the training, we obviously don't need to travel, and for schools as well, there isn't that demand to travel, so it means that it is that little bit more accessible, and it means that we were able to have been able to put on training sessions and have representation from across Northern Ireland, which is wonderful. So we targeted the training at special needs coordinators, SENCOs, and this is due to their key role in schools in terms of supporting pupils with additional needs. And as we said, we've been running this jointly with the clinical staff from the Children's ABC service and with ourselves in Educational Psychology, just to really capture that breadth of knowledge and experience between the different teams and the different staff. And our hope with the training is that schools will be better prepared to support pupils, and that they will know to ask for help at an earlier stage maybe rather than something later, and that they'll be aware of some of the issues that might arise and how to prepare for that. So we are running it as a pilot at this stage, and our aim is to continuously improve the training based on the feedback that we receive. So this is just some of what we cover in the training. So basically in the training, we're trying to address the knowledge gaps in terms of, you know, some basic information on the brain, recognition of the terminology used. As others have already said, you know, that's not really common knowledge within the educational sector. A lot of the terminology is confusing, I think, unless, you know, you're part of it on a day-to-day basis and you have that knowledge. It's really unclear at times, and also just what the impact of an acquired brain injury is, and how best to meet a child's needs. There are a lot of tricky areas there, and during our training, you know, we have conversation in and around what's helpful and what works regarding good practice, and through case study discussion, and we find that has been helpful so far. So one of the key areas, I suppose, that we had to really outline in the training was what actually is an acquired brain injury, because there's a lot of confusion around this and a lot of misunderstandings, and particularly for educational staff who perhaps really have very little knowledge of this before it perhaps presents themselves within their schools. So this is something that we really have aimed to try to address in our training. And I suppose we know that within Northern Ireland, you know, there are a large number of children and their families who are likely impacted each year by acquired brain injuries. And this means that there's scope for a very large undertaking of work, perhaps, and support that may be needed annually. And that's not taken into account the number of children and young people already living with acquired brain injuries in Northern Ireland who may continue to require support, you know, at different stages of their lives, I suppose, specific to us at different stages, you know, of their time at school, and ensuring that there is that understanding, and it just really shows the level of input that may be required from different services along the way, and the training that may be needed, and I suppose why that's relevant and necessary.
So we spent some time in our training as well, just highlighting the different areas that can be affected in the child's presentation. And really each of these are so essential for basically a good day at school. And while the learning one is maybe the more obvious one that springs to mind in curriculum access, actually when you just think of a typical school day, there's lots going on there. There's making friends, there's moving around school, there's using equipment. So it can have a really, really impactful, kind of significant impact on children and how they can even access education and access a full day or a full week as their peer group would. And I think that is part of the challenge, and that it's maybe prioritising which of these needs need input first, and whether that's offered through school, through other services, and where that joined up working can then come from. We also talk through the different stages that the school may need to consider. So we'll just run through some of these. So thinking about if any conditions were maybe there pre-injury, or other factors that may then impact that child. The injury itself, of course, thinking about the child and how they have been impacted. But again, if there's maybe wider implications for that, so in critical incident response, at times there's media coverage of that. And you're also thinking about how that information can then be given to other people, respecting the confidentiality of the child and the family, but making sure that those who need to know information can know it, and in a way that they can understand too. So in post-injury, we're thinking about all those systems again around the child, supporting that child and young person, their family, their peer group and school staff. And finally, planning for the future in thinking that there may be new difficulties or new challenges ahead for that young person as they progress through education. It may be that at the time of injury, particular difficulties weren't present that become more apparent later on. And that's a key one for schools, for when perhaps the brain injury happened when the child wasn't a pupil at their school, to be considering all those different factors. So when we're thinking about those different stages of supporting the child and all the systems around, we're then thinking about how children's ABCs and the Educational Psychology Service can be involved in supporting. So at a child level, we're maybe thinking about the immediate effects of the injury and different advice and strategies that need to be put in place, or more broadly, the impact of missing school, missing their friends, potentially having to change schools or not return to school. For the family then, there's lots of adjustments needed. There may be practical issues in terms of needing adaptations made to house, there could be financial implications of that, and just their own sense of loss and change as a result of the brain injury. For schools as well then, it may be that the pupil, as I said, can't return to school and has to move school. So a school might then be as having a new pupil, a child who's potentially had a brain injury, and just the knowledge and understanding around the impact of the injury and how that relates to special educational needs. So us as professionals, really around the child, the family and the school, being able to input at those different levels is really vital and really important. And again, knowing who does what and what time is best to do that in. So we've referenced the change of the code of practice. Previously, under the code of practice, ABI would have been referenced as a physical need, and that has changed for quite a positive reason, in that it can still be registered now as medical, but also under special educational needs. So that's thinking about if, because of the brain injury, a special educational need is now there, or prior to the injury, a special educational need was already identified. And I think this is a really helpful way of considering not just the medical implications, but actually then putting that into the context of how will this affect the child day to day when they're in school, and how will maybe their additional needs that were pre-injury also need to be kind of taken account of.
We wanted to make sure that the training was interactive and relevant as possible for educational staff. So we looked at addressing common misconceptions regarding acquired brain injury through polls and discussions, as well as explore challenges for schools around the changes to the legislation that Ruth has mentioned there, and also in terms of providing practical resources to the attendees, including things like return to school planning and case study discussion to give them, a real life view as to how this might play out within their school setting. So this is just, I suppose, a look at some of the things that we talk about with regards to a recent acquired brain injury and the child's potential return to school. So it's really a look at how schools can support pupils who've had a recent acquired brain injury with that return to school, if that's possible, by focusing on the key areas to ensure that there is information sharing, that there are support plans in place, and that there is collaborative working between the different, the different agencies involved in supporting that child, and to ensure that, the difficulties and strengths are recognised and just really exploring, how those things can be addressed. And one of the things that we devised then was this return to school checklist. And it really just looks at the different systems, I suppose, that are in place around the child and the child themselves, and what actions might be taken and by whom, and just really kind of exploring this in a clearer remit. So a really key thing to bear in mind here, and I know that others have mentioned this as well in their presentations, is the fact that we need for the voice of the child to be heard, and this is very much recognised and rooted within a number of pieces of key legislation. And I suppose as part of our job role as educational psychologists, in our work we very much do try to capture the voice of the child and advocate for their views to be heard, through our daily work and practice. And we want to make sure that we raise awareness of the legislation around this for schools, and to ensure that this is built into any plans for supporting pupils with acquired brain injury, in terms of what they maybe want to be shared or not shared, and to ensure that the schools and staff in and around those pupils are given that time to try to elicit the views, and we can perhaps offer some support into how to do that whenever it's maybe not so easy, such as if a child is non-verbal. And we can also guide schools in how mindful they are in and around what information can be shared, and I suppose what's confidential and what the child is maybe comfortable with as well.
So we've just had some kind of initial feedback to our pilot, and we were really pleased to see that some of the things that we set out to achieve were fed back as being achieved through the training. So just some really practical kind of things about setting IEP targets, knowing who to communicate with and about what, and just forming those links, and just being more informed in general about acquired brain injury and how schools can be kind of fulfilling their role to support children. We're really excited about this project, and we're keen to expand it as much as we can over the next academic year. Really keen to involve schools just to capacity build. So it may be that the school hasn't had direct experience of ABI, but actually through the training and through us working together, and we alluded to in our training, actually what a school understands as an ABI can be quite varying. So some schools might not think this training is relevant for them, but we actually feel it would be really beneficial. So we're just looking to improve our training as much as we can, improve our resources, and give schools really practical kind of day-to-day things that within the demands of a school day, they can implement to support the child. We are thinking a little bit about how, because most schools have a named educational psychologist, how we can use that even at the start of the new term or the new academic year to begin to identify children who have recently or previously experienced ABI. And just continue to make schools aware of using us as a resource and all those other services out there that would be really helpful for schools to be involved in. And I think just the overall aim for us all today is just really establishing those links between health, school, psychology service, and moving forward.
Ruth, thank you, and Maria, and apologies for popping up. I mean, that was a really interesting and comprehensive presentation covering a lot. I thought it was really interesting, setting the policy and legislative framework which has allowed you to deliver your work and set the context for it. Just in the time I have available, I suppose it maybe two very obvious questions. One, you mentioned it was a pilot, so I would just be interested to know the number of schools or people involved in the pilot and what are your plans for rolling it out. Secondly, you obviously mentioned the importance of partnership between health and education. Obviously, the third leg of the stool, if I may refer to that, fourth leg actually are both the voluntary sector and families. And I just wondered what your view is on what has been the experience of families and the voluntary sector influencing or shaping your training, and how do you see that relationship playing out as the training is rolled out? So a very specific question and more of a general question, if I could. Thank you.
Should I go for the first one, Maria? Yes, we've had 5 schools initially involved, and we're doing our second training actually later this week. And although we aimed it at special educational needs coordinators, SYNCOs, we did find that other members of school staff were enrolling in the training. So actually, through discussion with other psychologists in the group, we think moving it forward is actually extending it to all school staff that it may be relevant to. Particularly also if the child has a statement of special educational needs and there's classroom assistance in place, that person obviously is working most closely with that child or young person. So that would be kind of one of our main ways of moving things forward, and deciding whether even at different ages, maybe different training is needed. So what's relevant for a primary school environment is maybe less relevant for a post-primary school environment. So just to maybe tailor it a bit more to different schools and what their needs might be.
Lovely. That's great, Ruth. Maria?
Yeah, I suppose I'll take on that second question that you asked there, Joe. So I suppose, you know, in terms of the role of families and voluntary services, certainly, you know, we're always very keen to be involved with families and with voluntary services, whether they're already involved, you know, with a family that perhaps that we are working with. I think in terms of, you know, the training that we have been delivering, certainly I've had experience, you know, of placement within Brain Injury Matters, and obviously both Ruth and I, through our own, you know, role as educational psychologists, have both had, you know, casework which has involved pupils with acquired brain injuries, and, you know, we work day and daily, I suppose, with parents and with pupils in our roles. So I think all of those things have very much, you know, come to inform the training that we're delivering and some of the things that we have experienced along with our colleagues who helped us in delivering the training and in preparing and ensuring that it kind of got off the ground. And I think it's something that we're hoping to continue to build upon and hope that those partnership links can continue to grow. I think that we're really going to have to wait and see how things progress, and hopefully these are things that we can take further as our training kind of continues to be rolled out.
Lovely. Maria, thank you. And thank you, Ruth, for a really comprehensive presentation. I'm mindful that we've been pushing you on time here this morning. I just wanted to draw this morning's sessions to a close, and just to thank all the speakers who participated so well this morning and providing really, as I say, comprehensive, very interesting and challenging presentations. We have a number of questions which we'll pick up during the day, and also questions. I would say if people are posing questions anonymously, it's obviously slightly more difficult to come back and respond either during the day or follow up. So if you wouldn't mind saying who you are, that would be great. So thank you for your time and attention this morning. We're breaking now. It's now just after 11:05. We're due back at 11:15. I'm going to, with your support, move that back to 11:20 to allow our next speakers to get ready. But and coming into the next session again, just encourage everyone to come back and provide questions as much as possible. So thank you again for this morning, and look forward to joining you at 11:20. Thank you very much.
Good morning, everyone, and welcome back. And I hope you were able to grab yourself a wee cup of coffee there. So I am Bridget Smith. I am the head of the Children and Youth Service at Brain Injury Matters, and I want to thank you all for attending the conference today, and I hope you're enjoying it so far and getting a lot from it. So I'm going to introduce you all to the next section of the conference, which will concentrate on Brain Injury Matters, and in particular the Family First Service. So Meg and Catherine will be up shortly, and they will be exploring some of the work of the Family First Service, working with children and their families 0 to 12. And then we will have Dr. Chris McCusker, who will detail the 5-year evaluation completed in July 2020 of that service. And then later in the day, you will hear from Susie about Youth Matters. So just to give a little overview of the Children and Youth Service, we support children and young people 0 to 18 and their families with acquired brain injury. And that's a regional service, and it covers all of Northern Ireland. The service is funded by the National Lottery Community Fund, Children in Need, and other small funds, and this funding will draw to a close in 2022. The service is also run in partnership with the psychology services of the Belfast Health and Social Care Trust and Children's ABCs, and that supports the clinical governance of the work provided. But in recent, Brain Injury Matters has supported some of the Children's ABCs training programmes in terms of family-focused interventions. We also have 3 full-time and 1 part-time staff members with backgrounds of speech and language, psychology, social work, nursing and play therapy. So a differing range of skill sets, knowledge and expertise. The service provides family-focused interventions, and that is a whole family approach, working with the child, young person, parents, siblings and extended family. It's very much an intensive support with the family for up to a year, working within the home environment, online and via telephone. The service is very much bespoke and is tailored to the family's needs around the acquired brain injury. The work is very much evidence informed and draws on research and best practice in terms of acquired brain injury, trauma, parenting practices, mental health, sensory-based interventions, and that's to name but a few. We're very much solution focused, using the problem-solving approach to empower the family, and work very much from a systems-based approach, linking with the family, schools, community, other professionals, and the other charity and voluntary sector. We also provide social events, and that's fun activities for the whole family, which facilitate connection and interaction and peer support. And we do have an online support for families as well, and that's where they can access a variety of resources, activities and information documents. And they can communicate on a one-to-one basis with their practitioner, either through written communication or through video calls. And families can connect with other families for peer support. And we're currently in the process of developing a peer mentoring programme, and that is where young adults with an ABI become mentors to a group of 13 to 18-year-olds with acquired brain injury. So just to give you a little bit of the development around how the programme came to be, So research and our work with families has shown that the impact of acquired brain injury goes beyond that of the child and can adversely affect families. And living with a child with an acquired brain injury, or the invisible disability as it is commonly referred to, places enormous stress on families, parents and siblings. And there can be increase in family tension, conflict between family members, difficulty adjusting to new roles, social isolation, financial difficulties, and again, that's to mention but a few. There is consistent evidence that suggests that healthcare professionals focus on the medical aspect of recovery rather than taking a holistic family-centred approach to care. And often upon discharge from hospitals, family have described a realisation that the family must now go it alone, and often creating a sense of abandonment and anxiety among families. However, studies conducted here in Northern Ireland and internationally show that interventions that promote family functioning and the capacity to meet the changing needs of an injured child over time have better outcomes for families. Family-focused interventions which relate to things like psychoeducation, problem solving, family communication, meaning making, resilience training, benefit not only family adjustment, but ultimately the outcomes for the child. So given this evidence and the fact that there was no specific regional or trust-wide community service for children with acquired brain injury, nor specific statutory service designed to holistically meet the needs of children with acquired brain injury, as is still the case, in 2013-14, Brain Injury Matters started consultation with stakeholders, and that was to identify gaps in needs. Results clearly indicated that families required more intensive support than what current services were able to give. And with that, the Family First Service was born. Brain Injury Matters, in partnership with the Belfast Health and Social Care Trust, funded by the National Lottery Community Fund, set up a specialist service to work with children 0 to 12 and their families. And the idea is that that would bolster family resilience and problem solving. Excuse me. It would facilitate adjustment to the losses and challenges precipitated by the brain injury. It would also try to promote family cohesion, communication and effective parenting. It would increase understanding and meaning making, and it would reduce the negative impact of cognitive, emotional, behavioural difficulties in the child, but also to reduce distress and adjustment difficulties in parent and siblings. The idea is that this would be done both individually and in group sessions. And it was envisaged that a parenting programme would be devised and delivered by the team to help parents manage the behaviour of the child. Services have evolved over the last 5 years, and that's been in response to service evaluation, service user involvement, multi-agency feedback, and reflective practice. And the workshop model of intervention hasn't as proved as successful as was anticipated, and rather it is really the bespoke, tailored individual family interventions that have worked better. And that's been so much so that the project has extended its family-based support to young people 0 to 18 and is now amalgamated to the Children and Youth Service. So I want to thank you all for listening. That was a whistle-stop tour of the Children and Youth Service, but I'm now going to hand you over to Meg and Catherine, and they're going to go into more detail of what the Family First Service looks like. If you have any questions, feel free to use the Q&A function and we will answer those at the end of the presentation. Thank you, and I hand you over to Meg and Catherine.
Good morning, everyone, and thank you very much, Bridget. My name is Meg, and Catherine and I work within the Family First team in Brain Injury Matters, where since March last year we've been working virtually, like so many others.
Sorry to interrupt you, it's Catherine from ND Events. If you just want to, your slides are on your notes. If you go to display settings at the top there, if you share screen again. And then in the middle at the top says display settings. Click on that. And then can you swap to the full slideshow?
Is it easier if I just stop sharing? I don't think whenever I go to display settings, it's not giving me any options.
Yeah, try that, Catherine, that would be great. That's us, thank you.
Okay, apologies there, we had a sort of technical hitch there, but apologies, we're hopefully back to everything now. Good morning everyone, and thank you all for attending. My name is Bridget, my name is Meg. Thank you, Bridget. And Catherine and I work within the Family First team in Brain Injury Matters, where since March of last year we've been working virtually like so many others. As Bridget has said, we work from a trauma-informed perspective, and we use a range of theoretical modalities that we consider as appropriate to the child and the families that we are working with. As you'll see from the latter part of our presentation, our work draws on a range of theorists such as Abraham Maslow, Yuri Bronfman Brenner, Dan Siegel, Stephen Porges, Deb Dana, Bruce Perry, Karen Treisman, Gaber Matt, Gary Landreth, Lisa Mosconi, to name just a few. In our short presentation this morning, we hope to take you on an experiential journey to illustrate some of the experiences of the children, young people and families affected by ABI that have engaged in our services. We hope to show you that this is not always a straightforward linear path, but that it is a journey. For this, we ask that you engage with the presentation and trust us. However, please look after yourselves and do not engage with any activity that you do not wish to. Our presentation then hopes to give you a flavour of some of the practical tools and the strategies that we use with children and young people affected by acquired brain injury. We will provide some case examples on how these strategies were implemented with children and young people and families. Some families have kindly sent in photographs to help with our presentation today, and have given permission for us to share these. However, we do ask that you respect the confidentiality of these families. Firstly, I would like to give you the opportunity to take part in an experiential journey to enable you to experience and explore from a somatic and a sensory basis some of the sensations and feelings some of the children and young people we work with experience regularly. Given that this is a virtual experience, I would ask that as far as possible, you try to suspend disbelief, listen and explore the journey that we are trying to take you on. And also that if during this experience, there is anything you find unpleasant or difficult, not to continue. To begin, I'd like to start by asking you to sit comfortably with both of your feet on the floor. Take a brief look around your surroundings, your kitchen, office, and take a few minutes to acknowledge where you are and that this environment is familiar to you, that you are safe and secure. Now I'd like you to uncross your arms if you had them crossed, and then cross them in the opposite way to which you normally would, and take a moment to consider that feeling and consider where you feel the sensations. Do you feel annoyed? Do you dislike the awkward sensation? Does it feel uncomfortable? Do you want it to stop? Now do the same with your legs, and again consider the feelings and the sensations as you stay with these feelings for a moment. Now add in a memory of an unpleasant, memorable experience where you felt uncomfortable and you wanted to leave, or for that experience to stop. Maybe you were driving somewhere and you were late and lost. It was dark and it was raining. You were alone and there was no one there to help you. Maybe you lost something precious and important to you and you cannot find it, no matter where you look. Keep focusing on these sensations, and for a few moments let these feelings take over. And let your body take hold. Let that sense of discomfort and dislike rise to mild distress and panic. Let your body experience the sensations of tight shoulders, tight jaw, clenched teeth, tight hands, tight fists, dry mouth, tight face, tight neck, tightened body. Feel the awareness of your breath and breathing. Now I'm going to ask you to let go of that sensation. Leave that memory behind. Come back to the room that you're in. Let your eyes glance around the room. Take in the familiar shapes, textures, focusing in on something you like or that interests you. Notice its shape, color, texture, size, purpose. And as you do this, let your body come back. Now I'd like to ask you to stand up and stretch and take a moment to move your arms and legs and move from side to side. I'd like you to take a moment to reflect on the experience that you just kindly taken part in and reflect on the sensations and feelings of increasing discomfort and consider the impact of these sensations for you, albeit in a temporary and controlled setting. Many of the children and young people that we work with can experience these sensations of discomfort and dysregulation regularly. Now, before we move on, I'd like you to take a moment to practice a short grounding technique that we use regularly with our children and families, using a 4-2-4 breathing exercise as shown on the screen. So if we start by just allowing your breath to come in for a count of 4, your own count. We'll hold your breath for a count of 2. And then exhale for a count of 4. Hold for a count of 2. And we're going to repeat once more. So inhale your count of 4. Hold for a count of 2. Exhale, count of 4. And come back to the room. Thank you so much for taking part in that experience. We hope that we have illustrated some of the challenges experienced by some children, young people and families affected by ABI. As you can see on the screen, the impacts of ABI are diverse and complex and are as individual as is the work that we do. I'd like now to hand over to Catherine to continue with our presentation.
Thank you, Meg, and hello, everybody. As Meg has hopefully illustrated through that experiential journey, children, young people and families that are affected by acquired brain injury are faced with many, many challenges. Some children, young people will enter into our services with multiple impacts following their ABI, many of which are shown on screen. There can also be outside influences at play as well for children and young people with acquired brain injury in terms of adverse childhood experiences. The complexity and the diversity of a childhood brain injury also poses many challenges for us as a service. One of those challenges might be that quite often children and young people are referred into our service and have not previously ever had a cognitive or neuropsychological assessment conducted. Quite often we do not have that full picture of what a child or young person's needs might be. So we may quite often refer back to the community paediatrician to seek that assessment, as not having that clear picture of a child's level of functioning can really impact on the interventions that we do. Having said that, we would now like to give you a bit of an insight and a bit of a flavour into some of the work that we do with children and families who are affected by acquired brain injury. Very much at the foundation of the work that we do is to build that relationship with our families and to attune to the needs of our families. We do recognise that for a lot of families there can be fractured attachment, be that the parent's relationship with the child who has an acquired brain injury, potentially due to behavioural challenges, a change in personality, tension, conflict within the home. There can be fractured attachment within the home due to the added pressures that acquired brain injury has on families, again, tension, conflict, or there may also be fractured attachments with other professional services. So one of the key things that we do whenever engaging with families is supporting parents to attune to their child's needs, and we do this very much by trying to attune to them and to their needs. A key element of the work that we do is psychoeducation, and that is very much woven into problem-solving therapy and tailored specifically to the developmental needs of the child and the acquired brain injury challenges that that family are experiencing. Linked to that is supporting the family to engage in meaning making and supporting them to emotionally process their experiences of acquired brain injury. This is all done in that very multi-systemic way where we attend to the wider circles of influence. That was very much alluded to in Yunan's presentation today, where the wider circles of influence were discussed and in terms of that Brenner's model. So this might be through liaising with school, empowering other community healthcare workers, education sectors with child-specific information or ABI information. We might do extended sessions with the wider family circles, with grandparents, aunts and uncles, or we might link in with play specialists in hospitals, maybe to support children who are going for a procedure in a hospital setting. So from that work, we have a very solid foundation on which we can then apply practical strategies to support and empower children, young people and families who are affected by acquired brain injury. We do this maybe by drawing on some cognitive models, play-based techniques, sensory models, behaviour strategies, and that is very much going to be the focus of the rest of our presentation today in terms of showing you some of those very practical tools and strategies that we use whenever we work with children, with families, with siblings. As previously mentioned, we have consent from these families to share their stories and to share some images, but we do again ask that if you do recognise any of these families, any of these images, that you do respect their confidentiality. So this first example is an example of a child who's 10 years old, and this family was looking for support, for some support for their child who was displaying some very repetitive behaviours, was struggling to transition into different activities, and this was having a wider impact in terms of family life and the activities that they could do together as a family. This young girl was presenting as very anxious, and she had this very special interest in a toy called Vector. So as part of our intervention, Vector was used and brought into the intervention, and this young girl was repetitively asking questions about Vector, repetitively asking her parents to engage with her robotic toy as a distraction whenever she was feeling anxious about engaging in different activities. So as a service, we helped this family create visual cards, which were Vector cards, as you can see on screen, and the parents have very kindly sent us into them today for us to share with you all. In this intervention, Mum had 3 cards and Dad had 3 cards, and she was able to use these visuals to communicate with her family and transition into other activities. So this visual behavioural strategy limited her repetitive behaviours and supported her transition into other activities. This strategy was also then implemented into the school setting. So the school were able to have that continuity between what was working at home and what could be implemented in the education setting. And it supported her in terms of setting boundaries and transitioning into other activities in the school setting. This is an example of how visual aids were used with a 7-year-old girl who had sustained her acquired brain injury through a non-accidental injury. Mum reported this young girl was struggling with listening to instructions, struggling with communication, her emotion regulation, and activities of daily living and daily routine. So we very gradually started introducing visuals into this family's routine by starting to use emojis. And initially this was very small in terms of only using happy and sad, and we very gradually extended this form of communication over time. Into other emotions, into communication such as good listening, or it was time to do homework, and activities involved in daily routine. Mum would describe that this girl is now reported as being much more self-aware. She's very able to appropriately recognise emotions in other people, and the parent-child communication has really significantly improved through the use of these visuals. This next practical tool and practical strategy is one that we have used both with children with acquired brain injury and also with their siblings as well. In this example, we were working with a child who was 8 years old and was displaying behaviours that challenged Mum in particular. He was presenting as very angry, and Mum would describe him as going from 0 to 10 at the flip of a switch. We worked with this mum and with both her children to create a collection of tools that support this boy's regulation, both when he was escalating in behaviour and also tools and strategies that he had when he was at that crisis point of his challenging behaviour. Sometimes this tool can be referred to as a grounding box, a sensory box, a calming box. Really, it could be named whatever makes sense to that family or whatever that young person wants it to be named. For this young person, it was named his calming box, and he covered it in stickers and photographs of wrestling and things like that that made him happy. So initially, whenever he saw his box, he initially felt happy and connected to it. All of us have very different sensory profiles and very sensory needs. So some children might want things in their box that are uplifting and will upregulate them if they were feeling low. Other children might be feeling a little bit stressed, worried or anxious and need something to bring a sense of calm or something that brings a sense of grounding to them. So using all the senses, we supported this mum to create this box and to fill it with things that would make her young boy feel calm, feel happy, feel grounded and feel regulated. Some examples are shown on screen of things that can be included, but we really trying to incorporate all the senses, as I said. So in thinking about things we can smell, this young boy really enjoyed bath bombs, so we incorporated those into his calming box. When thinking about things that you can touch, this young boy included things like colouring books, colouring pencils, a squishy ball, a sensory toy, to really help in terms with that regulation. You might also want to include things that you can hear or listen to, so maybe a device or your headphones, and have a playlist on hand, or meditation apps can be really useful. And finally, we wanted to include something that you might be able to taste. So for some people, this could be their favourite food or something to chew. And this young boy decided to include his favourite bubble gum within his calming box. Other really useful items to maybe put in such a sensory box or a calming box maybe could be bubbles to blow or balloons to blow in order to do some breathing techniques. Different things really do work for different people, but this has been a strategy and a very practical tool that has worked well with a lot of our children and young people, both with acquired brain injury, but also their siblings as well. This was a really lovely piece of work that we did with a young boy who had sustained his acquired brain injury following encephalitis. He was age 9 at the time. Whenever we first met this young boy, he would have presented again as quite angry, unwilling to engage, very negative about himself and his self-image. So we began some life story work with him and with his family, looking at his life before his injury and his time during his injury and when in hospital and some time after. I'm sure many of you have maybe engaged in some of this work before, but for any of you who maybe don't know, the life story work is really to support children and young people to understand and accept their journey. And we very much supported this young boy to process his emotions and to express his emotions, both those that are positive and negative, or good and bad. And you can see at the top there, he's written, "I probably felt sad." And a lot of the stickers and things that he would use would have been of a more cross or sad expression whenever he was in hospital. As you can also see from some of those images, this young boy would have covered his face in photos, be that with maybe stickers, stamps, or by drawing on his face. This was really particularly difficult for Mum, and she really struggled to see her son to face the photos in this way. So we very much worked therapeutically with Mum as well, engaging in meaning making, encouraging her to take part in this life story work as well. She was also encouraged to do some therapeutic work, and she found that journaling was really helpful throughout her journey of doing this life story work as well. For this young boy, we also incorporated a lot of movement breaks into our session. That was very much needed in order to incorporate some regulation and engagement into this life story work. So more recently, this young boy has been described as being much less angry, and Mum herself has also reported that she's much more content, happy and feeling empowered and confident. We actually had email correspondence recently with this mum whilst we were asking her for consent to share her story and to share some images. And she reported that although this work was almost 2 years ago now, she continues to see the benefits that this young boy is receiving from doing this work, and he was described as being much happier and much more content in recent days. A lot of the children and families that we work with will continue to have hospital appointments or hospital visits following their acquired brain injury, and that can be very challenging for the children themselves, but maybe also for the parents too. One young boy in particular was described as having medical trauma following his acquired brain injury, and mum was finding it really difficult to bring in for hospital appointments and MRI scans. So we did some play-based work with this young boy where we created an MRI tunnel from cardboard, which is pictured there with the reflective surface. And he was encouraged to paint the inside of it, decorate it with stickers, with words, with drawings or images, whatever was fun and which was engaging for him. We explored some creative ways to slide in and out of the tunnel, such as maybe on a skateboard, a towel, a baking tray. And we also encouraged his teddies and toys to go through the tunnel and engaged in some role play where toys were worried about going through the tunnel, and we would engage in some role play about coping strategies and emotional regulation. For this intervention, it could also have been a fun idea to have the children and young people wear headphones or wear ear defenders and make lots of noise and have them slide in and out of the tunnel as well. The point and the purpose of this intervention was really to give the children that somatic experience of laying flat or of their body being surrounded by something like a tunnel, or to help them maybe process previous experiences that they have had in hospital. For this particular young person receiving their MRI also involved a general anaesthetic. So we supported mum to make masks and to practice breathing techniques with these masks on. Again, breathing activities might include things like blowing bubbles with the masks on or blowing into a balloon. This particular mum also had an air chamber at home, so she used this to give her son the bodily experience of breathing into the mask in terms of covering his mouth and nose and encouraging him to do some deep relaxation breathing techniques. And again, she's very kindly sent a photograph into the conference today to illustrate that. This again intervention really gave that young boy the bodily experience, helped him to reduce his fear because he had had that experience before. And in this particular experience, we worked very therapeutically with mum as well, helping her to process her own trauma, explore her own experiences, fears and barriers in that very safe environment. And finally, as a family-centred service, we also do support siblings. And this is an example of a sibling whose brother was involved in a road traffic collision, and he had sustained an acquired brain injury. This young boy was also involved in the same road traffic collision as well. And he was presenting as very anxious and developed a fear of travelling in cars. So we worked with the sibling in this family as well, very intensively, and we drew on that cognitive model, helping him to understand his thoughts, his feelings, behaviours, helping him to understand where his anxiety came from, those avoidance behaviours and those maladaptive coping strategies. He was supporting with understanding, as I say, how his fear developed and why he was then acting the way he was, and maybe how to have some strategies that would more appropriately support his anxiety and support his mental health. The remote control image that you see on screen was a resource that was created within Family First Services as a visual aid to appeal to young boys, maybe more in particular, although I will not generalise at all, but anyone who is really engaged or really interested in gaming. So the idea is that each function of the remote control represents a different coping strategy or technique, and it's very much created as a visual aid to help people who are used to gaming or used to looking at visual remote control some of the different strategies that they might be able to engage in order to look after their own emotional well-being or mental health. So this resource worked really well for this sibling. He was equipped with the techniques in order to engage in self-care and had this, as I say, as a visual aid to prompt as a reminder. There are some more visual examples on screen. There are many more practical tools, strategies, ideas, games that we would have loved to have shared with you and to have talked about today. We are more than happy to be contacted at a later date or for anyone to get in touch, and we can maybe share some more examples, or if anyone had any questions about some of the practical tools and strategies that we have shared in our presentation today. Finally though, to finish up, we wanted to end on the same note on which we started. We've given a very brief insight into some of the practical tools and strategies that we used or do use with children and families. By no means that was an exhaustive list, but we do hope that it has hopefully provided you with a flavour of some of the strategies that we use within Family First, or maybe can help you to reflect on your clients or your caseload, and if there's any practical tools and strategies there that you might be able to take ideas from when working with your own clients. We do hope that is helpful, but as I said at the beginning, at the very core of the work we do is to really build that relationship with children, young people and families. So that is us. I'm surprised Joe hasn't popped up, but we're open now for any questions. Oh, there he is.
Thank you, Catherine. That's my prompt. Catherine, thank you and Meg for a really fascinating and also very challenging presentation. I loved the opportunity at the beginning to practice some of the sensations or feel those sensations, and the very practical tips around grounding and the calming box and the MRI tube, making your own. And I suppose also the emphasis on bringing families and bringing parents with you on that journey. I mean, it's really very, very moving actually, and very, very practical. I would be slightly biased, as you, obviously, given my role in Brain Injury Matters, but I also maybe just wanted to pose a couple of questions to you in terms of general questions. Coming out of last year and COVID and the challenges there, your emphasis on very practical support, how did you manage during the year to make that adjustment from being in the house one-to-one to working remotely? And secondly, how would you see services going forward, building and learning from last year? How would you see the service continuing over the next few years? So I'll maybe stop with that and pick up other questions as they come in. So over to you.
Do you want me to take that one, Meg, or do you want to go ahead?
I do. I'm happy, Catherine, whatever I can pick in, whatever you haven't covered. So, yeah.
Perfect, yes. So no, very much so. Over the last year, I'd say has been very challenging for a lot of services. I think as Katie picked up, not only just in Northern Ireland, but maybe across, the whole world over the last year. Very quickly, we moved to remote services, and I've been offering services in terms of maybe over the telephone or on Zoom. In a lot of instances that has worked very well, but of course that does pose a challenge for working with some of those younger children, and especially where previously we would have been in the home, we would have been quite literally on the floor crawling through those tunnels with our children and young people, and obviously that isn't the way we're able to work at the minute. So a large part of our work over the last year has very much been with parents, really empowering them to have these skills, to have these strategies, and showing them and teaching them how to do that work possibly themselves at home. That example of one of the masks was one that was conducted during COVID, and again, Mum really listened and adapted the strategies and things that we were telling her to what she had available in her home and to what suited for her and her family. So as I said, it has posed a little bit of a challenge in terms of engaging with some of our younger children. But again, that's not a wide sweeping statement either, because some young children have been very happy to maybe contact us through the likes of a video call or, to speak to us on Zoom now and again. So it's been very blended. And that leads me, I suppose, into your second half of your question, Joe, about how we would see things going forward. And that really is maybe having that very blended model and blended approach to both offering services remotely, but also continuing to offer face-to-face as and when we are able to do so. I think both equally have their place, and I think parents would actually very much enjoy having the option. As I say, some work is more suited to be done face-to-face, but there have been a lot of successful interventions and successful strategies delivered throughout the past year, even though we haven't been able to get into people's homes.
Thanks very much, Catherine. Meg, anything you'd like to add to that or build?
Yeah, I would agree very much with what Catherine said, and I do feel going forward a blended approach is probably the way to go, and I do think the sheer logistics of trying to see a family in Derry and trying to see a family in Fermanagh and another one in Portadown, that can all happen in one day now, whereas pre-COVID that wouldn't have been the case. So I think, from a logistic point of view, I think it's possible. I also think that we're able to be more flexible and meet parents and families' needs. We can offer sort of tea time appointments because they're on Zoom, or it's on a telephone call, and again, early evening, things like that, which fits into what a lot of families are wanting and requesting. So that has been really good. I think, thinking about something a couple of other friends were talking about this in terms of my own learning. As a therapist and as a clinician, some of the things I have really learned and delved deep into myself over the period has been my ability to attune to parents and to children, and that for me has been a significant learning. I guess I felt previously to this, probably especially as a therapist, I felt I did attune to the families and to the children I work with, but COVID has really stretched me from that perspective, and I have understood, I guess, on a deeper level, I've understood especially the importance of listening, and really listening to what children are saying, listening to what parents are saying. And I've been working with quite a few families who don't want to use Zoom and who don't want to use video contact. So it has been purely listening to them. And that sense of that relationship building purely by an auditory means has been enlightening, really quite amazing. And I was very honoured to be taken by a young boy who's really struggling, and purely by voice, he took me with his mum's mobile phone into his dark den, where we sort of discussed some of his challenges and some of the difficulties that he was coping with. And that was a really powerful experience. So I guess I feel I've learned a lot, and I hope I will continue to.
Meg, thanks very much. And I think just illustrates your last slide about touching the human soul. Maybe just one final question, just an observation, and knowing you both a wee bit in terms of your backgrounds from different clinical backgrounds. I mean, how important is I suppose the question of being a multidisciplinary team, because you two, and I know Bridget comes from a different clinical practitioner background. Has that been an important aspect of your work and your success?
Yeah, I would say very much so, very much so. I mean, certainly whenever I first entered into the service, the idea of those play-based techniques maybe slightly more alien to me. If I can reflect that, you know, a lot of my training would have been on those very cognitive strategies, and we bounce off a lot in terms of our different disciplines and different ideas that we can take from each other into our clinical work. We discuss that every week at a clinical team meeting, and we do that formulation, and we do those clinical meetings where we suggest and sort of brainstorm different techniques or different interventions. And absolutely, it's I think it's very powerful in terms of having that multidisciplinary team for going forward and moving with it, or working with children who have acquired brain injury. Thanks,
Catherine. Meg, any comments on that or reflections from your own experience?
No, I would completely echo what Catherine has said. And I suppose some of my past work, I've worked alongside OTs and physios, speech and language therapists, and other clinicians. And when I've been lucky to have those opportunities, I just feel it's a deeply enriching experience for everyone involved. And at the end of the day, hopefully it will enrich and give value to the work that we're doing with children and families.
Lovely. Well, Catherine and Meg, thank you both very much, and I appreciate we could spend the whole day looking at your practice, so it's been fascinating. Thank you again, and thank you to Bridget for setting up the session in terms of the overview of Family First. Thank you. I'm now going to move on. Thank you. I'm going to move on to our next speaker, Dr. Chris McCusker. Dr. McCusker has been a long-time friend and colleague of those of us within Brain Injury Matters. We've heard Meg and Catherine talk about the practical aspects of the work. Chris has been working alongside us in terms of the review and evaluation of outcomes. And this morning, Chris is going to focus on the outcomes from Family First, and also, and I think very helpfully, give us some pointers and suggestions in terms of the way forward for the services. So thank you, Chris, for joining us, and over to you.
Okay, thanks, Joe. Can I just check that you can see my screen there? The presentation?
Yes, I can, Chris. I just checked with Catherine.
Okay.
Yep, we've got it. If you just put it into the full slideshow mode, and we're good to go. Thank you. Okay,
good. Yeah, so I was involved with Family First right from the beginning when we first made the bid to the National Lottery. And then when I left the Royal, I became the external evaluator for the project. And I want to share the findings of the 5-year review, because I guess, you know, it's really important to ask the question, does all of this actually work? Does it make a difference given the investment and so on? And you've seen this model. This was very much what Family First was based on. So what happens to the child, any child, is not just about themselves, their personality, their traits, their intelligence, but about the systems that surround them. So the macro systems such as our culture, state laws, socioeconomic status, these all shape our opportunities in terms of life, our attitudes, our attainments. But really, in my work with children with brain injury, but also children with other chronic illnesses and disabilities, this mesosystem, and especially the family, has been an important influence in development. And not just in terms of normal development, but in terms of adjustment from any chronic illness or disability. So, you know, even more than the severity of the disease, the severity of the injury, the amount of medical interventions that are required, our work has shown that family functioning is often a bigger predictor of outcome for these kids and young people than the disease itself, than the severity. And many of us will be familiar with kids who've had very severe brain injuries, but actually do very well, have good outcomes in terms of quality of life, adjustment, happiness, and other kids with relatively mild conditions who have more difficult outcomes. So this slide just illustrates that across multiple conditions, so this first box, family cohesion, conflict, parenting style, was a greater predictor than seizure frequency in terms of behavioral difficulties in children with intractable epilepsy. And I found that in various research over the years. Similarly, children with congenital heart disease, maternal mental health and worry, greater predictor than the severity of the condition when we looked at behavioral outcomes for children sometime later. Similarly, with autism, rule setting, harsh punishment and parent discipline correlated with internalizing and externalizing symptoms more so than the severity of the autism. Seen it in cystic fibrosis, cancer and pain, and also in ABI in terms of parenting behaviors. So the evidence base has just highlighted a lot that family factors are a really important predictor of outcome. And that would tell us, therefore, that interventions should be aimed at bolstering family resilience and family functioning as much as the medical interventions to reduce the impact of the disease. But most importantly, over the past 10, 15 years, we're now starting to get a really nice evidence base which has started to show that interventions which are targeted at bolstering family resilience, coping, parenting adaptation, communication, meaning making, these sorts of interventions have been demonstrated to improve outcomes for the family and often for the child with a chronic illness or disability. So it's an indirect intervention. As opposed to working with the child or young person themselves, we work with the families, and through improving family resilience, we improve outcomes for the child. And this was the actual underpinning philosophy of the Family First project: improve outcomes for the child by family-focused interventions. And we've heard, some specifics in the last presentation about specifically working with the child. And we also, Bridget gave us an overview of all of these different sorts of interventions which are aimed at bolstering the family, family resilience, family coping. And largely this has been over the past 5 years through the home-based visiting programme, and more recently in the past year through tele and online sessions. Bridget did refer to family workshops, which brought together parents, child and siblings. And also a strong feature of the work of Family First has been starting to impact on that other system surrounding the family, which is the school system, the healthcare systems. And I've become really interested in how families interface with these systems, because the research in that area is only really starting. And it's really important, I think, in terms of thinking about outcomes. So I'm not going to go into the interventions. You've heard a bit about them. There's a report that I think is on the Brain Injury Matters website, which is the full evaluation. But rather, I want to ask today the main question: did it actually work? Did all of this, which sounds good in theory, did it have an impact? And there's three key questions here. First of all, did the project reach the target population, and did it reach it in sufficient numbers? What were the needs and profile of those who access the project to inform interventions? Because sometimes it's not always the people that need an intervention most who have the capacity to actually access services. And some hard to reach families, children in need, families in need, often just don't have the wherewithal to actually access. So I asked the question, who did the project access? And what were their needs? Secondly, in thinking about sustainability and maintaining this project beyond the life of the National Lottery funding, it's important to think about outcomes in terms of, did the families experience the service as helpful in terms of their goals, their needs, their presentations? Was the method of intervention acceptable? Was it feasible to the families? And then, perhaps most importantly, have the project interventions been helpful or instrumental to achieve the therapeutic aims and objectives of the project? So those are the three broad sets of questions that we're always interested in any evaluation of a new treatment or of a new service. And you know, at the interim evaluation, we talked about the importance of having an outcomes champion in the service, because when you're really busy trying to access families and deliver interventions, it can sometimes be difficult and challenging to keep data in sufficient detail and with sufficient thoroughness to actually be able to arrive at a point where you can ask the question, did this amount to a hill of beans? It all felt good at the time, but how did it impact on services, on families, on reducing disability and so on? Because those are the questions that commissioners want to know about in terms of future and ongoing funding. So what I've summarised in this slide really is some data related to accessibility. First of all, over the 5 years, 80 families engaged with the programme over fairly significant periods of time. I think the pie chart here that shows where the families came from, you know, the first thing that strikes me is 42% from the West, often a group of families that find it hard to access some of the specialist services in Belfast and even in Derry, because the West is such a rural and widespread area. So actually, one of the smallest groups to access a Belfast-based project was the Belfast Health and Social Care Trust, families. And I think this is really impressive in terms of the reach and the marketing and the going out there to publicise the nature of the project and the commitment to reach all families across Northern Ireland that was shown by this service, this project, right from the very start. This is not a more recent phenomenon in terms of distribution. We were seeing this almost from the start. The project in some ways has become a victim of its own success, in that now over almost two thirds of the referrals are coming from statutory services, health and education. At the beginning, it was much more self-referral, which is what was targeted, but still over a third are self-referrals. And then a wide spectrum of health and social care agencies, health education, different professionals. In terms of the needs of people who access the project, They're often almost 4 years post-injury by the time they get to the project. That figure's come down over the 5 years of the project. I think at the interim evaluation, it was 4 to 5, it was almost 5 years. So people are becoming aware of the project earlier. But this figure shows something else that's really important. This doesn't go away. The impact of a brain injury doesn't just recover as the broken leg heals and the cracked skull mends. The problems of acquired brain injury, unfortunately, are long-lasting, and in some cases actually emerge across time. Of course, there's recovery for a lot of kids, but for some kids, because the brain's still developing at a time of injury, we only see the problems 3-4 years later. Where we are accessing, and this is really impressive, I think, families in need. So 42% of the families, lone parents. We know that family composition is a risk factor. Lone parents, because they're managing so much, may not even be able to get to services, never mind avail of them. So this service is accessing lone parents. If we looked at the deprivation index, quite a lot are from the higher deprivation indicators, quartiles. Again, these are families and children who sometimes, when we do service evaluations, are missing from the profile because of the difficulties just in accessing. So again, this project has accessed families in need. The majority, 82%, were in what we call the moderate range of disability. Now, this is kind of misleading because it's based on disability ratings, and often physical disability kind of dominates this. But the kids with the moderate disability often will not have access to the specialist neurology services available at the Royal because they're not severe enough. They don't access Paul Ward and the associated services that go along with that. So they're often discharged relatively quickly. Often the orthopedic injuries dominate the picture. The brain injury may not get much attention, and they're in the mild to moderate range, which actually is the biggest percentage of kids with brain injury. However, I said it's a misleading title because actually 70 to 94% of these in the intake assessments were at threshold levels in terms of difficulties with specific physical, emotional, and behavioral problems. So these kids are going home, they're often not accessing specialist services, but they're demonstrating significant need that may or may not get picked up by services that are not particularly targeted at children with acquired brain injury. Again, almost 3/4 are in mainstream schooling. They're not severe enough to go into special needs education. So the real importance of the education initiative that we heard about earlier, they're in mainstream schooling, but of those who are still in mainstream schooling, 60% are actually in the process of statementing, which means they're not coping. And it's become apparent, and often it only becomes apparent a year, 2 years down the line by the time that process happens. So I think this is actually quite good profiling in terms of who is accessing this service, and is real testament to the project team that they've managed to break through here and reach this hard to access but high in need children and families. So in terms of thinking about outcomes, acceptability, and clinical outcomes, we approach this in 2 ways. I will present some hard data, if you like, where we use standardized scales, clinical scales, to look at profiles in terms of behavior problems, in terms of quality of life, and I'll look at changes pre and post involvement with the service. But I think it's always important to look at the voice of the families themselves. And a number of families, I can't remember the percentage, but it was quite high. I think it was about 3/4 of the families who participated in the project interventions also participated in the interviews, in the analysis of their experience. So I got lots and lots and lots of data from the project team, and essentially it boiled down to 3 strong themes, what I've called the superordinate themes. These were empowerment, family connectivity, and an accessible and important service. So this empowerment was all about knowledge and coping. So it was understanding. So I've given you some quotations, gave me a better understanding of the effects of brain injury. But also skills. I learned a lot from Family First, things I'd never thought about before or that no one else had brought to my attention. Here's a child talking about how they helped. I mean, this is remarkable that a child will basically give you a cognitive behavior therapy analysis of themselves. It helped me to think about my thoughts and how to help my feelings. Now that we saw that in that remote control technique that in the last presentation. So here's a child who learned to see that their thinking was affecting how they were feeling. And here's a sibling, helps us to understand how to take care of their sibling with ABI better. Another strong theme was this family connectivity, the sense of not being alone, meeting other families through the workshops, the online portal. It's good to talk to other parents, hear what they had gone through, hearing the child talking about hearing the story of other children, but also this family meaning making. And this has been a theme that come up, the communication, the making sense of why the child feels and behaves the way they do. Things are much better now at home when I speak to the kids. We understand each other a lot more and a lot better. That empathy, that understanding is hugely important. And then that finally, the accessible and important service. So some feedback on the fact that this has been a service where accessibility has been good. It's been a real lifeline, as one parent talks about it, and it's filled a gap. And this is a theme that came up in others. So what about the referrers, other service networks? Again, accessibility was a strong theme. There were 4 themes. When I looked at this data, you know, it was coming from GPs, from consultant pediatricians, from schools, from ed psychs, from all sorts of areas. And a strong theme was this accessibility, good feedback always provided, opportunity to link in and discuss. This is huge and also very time consuming because, you know, writing a report to another agency can go so far. But what I was seeing in some of the feedback from the referrers was conversations by phone, the reviews, the keeping in touch. They also were aware of good outcomes. You know, the service provided great support for client of mine. It was exactly what they needed. Child and family found it beneficial. So here we have not just the parents talking about good outcomes, but also the referrers. This is really important, this third theme, the impact in the service landscape. So we've heard a lot today about partnerships and the importance of them, the importance of imparting knowledge and skills. And it's wonderful to see a number of agencies now involved in this sort of work in Northern Ireland. But these referrers are saying, you know, about coming out, doing staff training, they worked alongside me, they're plugging gaps. And the suggestions that were coming through from this group of stakeholders was that it would be good to have even greater liaison. So on to some numbers. So this slide really just, before we go into the standardized scales, parents and children were really asked to endorse or disagree with certain statements, and the statements were balanced. They weren't all framed in the positive, but they were very much benchmarked against the mission statement, the aims, if you like. We looked at the original aims that went into the National Lottery in terms of funding, and they were very much sort of benchmarked against those. And we see generally very good feedback here. So both parents and children, at the interim evaluation, we didn't have the child feedback as much. So we have that here, and we can see that often it's a little bit lower than the parents. Sometimes it's higher in terms of their experience of it improving their relationship with their parents. But across both parents and children, we're seeing the dominant experiences in terms of positive outcomes related to understanding. And we've heard a lot about that today, that, you know, Eunan talked at the very outset about how he was sometimes taken aback at the lack of understanding of brain injury in other professionals who came across families and kids. And it's wonderful to see that these families, these children, are talking about improved understanding, improved capacity to parent, being informed by the reasons behind the child's behaviour, family communication, family functioning, and the parent-child relationship. So some of these formal outcome measures. So here we have the child behaviour checklist, a really common standardised instrument that is used to both evaluate children's needs, but also their changes following therapy. Now, the first two bars are child competencies. These really relate to academic and social competencies as well as activities. And the average here is 50. And when you're below 50, when you're below 40, 35, you're showing significant need, significant problems with your competencies. And first of all, we can see that the kids who access this service are at the threshold. I mentioned this a few slides back. Despite being in the moderate range, they're at threshold for need. And so they're at threshold for need before and after, but what we're very pleased to see is statistically significant gains in competence scores, so they improved. These next three bars are about behaviour problems, divided into externalising problems, that might be conduct problems, aggressive behaviour, social problems, and internalising problems, that might be anxiety, depression, mood disturbances. And again, this time it's the reverse. So over 65 is threshold, and we can see that again, these kids are meeting threshold for behaviour problems. And we can see it's not a panacea. These are coming down, but not to a statistically significant degree. But all of them are going in the right direction, which is good. And then in terms of the children's reports themselves, these were children who were able to engage in the self-report. So it's a smaller group. It's a different instrument called the Beck Youth Inventory. We see improvements in self-concept and reductions in terms of child-reported anxiety and depression, anger and disruptive behaviour. And indeed, reductions in anger and disruptive behaviour are statistically significant. Interestingly, based on the children's own reports, they're kind of in the average range. They're not showing the level of needs that their parents perceive of them. If we look at quality of life, so family functioning, family health, total score, and then child psychosocial, child physical, and child total, we saw, and I noticed on this slide, the significant levels haven't come through, but these last four, so the family total score and all the children's quality of life, all improved and to a significant degree. Now, we don't have control group here because the interventions were offered to all the children and families who needed them. It would not have been ethical to have withheld treatment in this particular project. But given that this, what we call triangulates with the thematic analysis, is quite strong evidence for, to attribute this to family first involvement. And this slide just looks at very specific goals that the families agreed with with the team and how close they were to attaining those goals. So that might have been around sleep, school reintegration, behaviour problems, communication, impulsivity. They were to do with all sorts of things. So at intake, they were not really very close to their goals on a 10-point scale. We can see how much closer at 6 months they were and how that was attained, that was maintained in terms of progress towards achieving goals. So we're never going to take all these problems away. These are, somebody said it's a lifelong condition. It's challenging, but if we can bridge the gap, this will be good. So just before conclusions, one of the things I did in the final project evaluation was conduct a focus group with the project staff who had been with the project over the years and who had a lot of insight and a lot of gains in their own development to share. And 4 main themes came through from that focus group. You know, one was that I'll talk about first was just the growing complexity. So I mentioned that the service has become a victim of its own success. And people often talked about the increasing complexity of the referrals that they were receiving. And when you listen to some of the work that's been done, you can see that many of the project team are acting like therapists and are therapists. They're not just providing support, they're actually engaged in therapeutic interventions. And I think that, you know, because of that and because of the outcomes, they're seeing increasing complexity. This evolution, this is about changes. So very strong theme, building capacity in others. So a lot of talk about the indirect impact, increasing interventions with schools. And it's really nice to hear there's a school education initiative starting, which could be helpful here in taking some of the pressure off Family First to do the school educations, or in terms of working together through doing that. Yeah. And the home-based visiting has just become the linchpin of the service. Strong theme about minding the gaps. That these kids often fall between a lot of stools, so they may be involved in lots of community services, education services. However, there's no overarching brain injury service, if you like, and that may not be the primary identity of the child. They may have other comorbid conditions, which I didn't talk about earlier, but which were definitely in evidence. But in terms of the brain injury, in terms of understanding what that means for education, for intervention, it seemed that the team were coordinating, joining up dots, bringing people together, and also delivering clinical or therapeutic interventions. And then a real strong importance in terms of statutory partnerships. So in conclusion, whose benefit? A lot of families with increasing complexity and children and families in need from right across Northern Ireland. The service has there's evidence that the service has filled a gap and increased capacity in other statutory services. And what difference did the project make? Improvements in child social competencies, child and family quality of life, and through, from what we heard, knowledge and coping skills and improved family functioning. The way ahead, I think, as is outlined in the report, a big challenge for Joe and the team is to think about mainstreaming this service, sustaining it beyond the charity funding, enabling the knowledge and skills of the team to keep pace with the complexity of the referrals that are coming in, to respond to the online groups, and we've heard a bit about that already, about what's going to be maintained, and to engage in a programme of research and dissemination to highlight the good practice, to highlight the findings that have come from these analyses, you know, beyond the service, so beyond Northern Ireland and indeed beyond that. So I'll finish there, Joe.
Chris, thanks very much. No, and I really appreciate that because, and again, you referred to the evaluations, a very detailed evaluation available through Brain Injury Matters, but you've really taken us through, you know, whistle-stop tour of a very comprehensive report. I suppose a couple of things stand out for me. One, and again, I am slightly biased, but it seems to me from your evaluation, the outcomes from the original project, which you were one of the architects of, have been, I suppose, both met and exceeded, which is, you know, tremendous in its own way. The second issue around the very strong involvement of families, again, you'll know from your own work, sometimes families are left out of the discussions. Your evaluation seems to very much bring families into the centre of it. I suppose the third point I want to raise, just to be interested in your view of where to next with this service. I'm very mindful you've used the phrase about filling the gap, and the danger is, as with all services provided by the voluntary sector, you have 5 years, 2 years later, people are saying, well, what happens next? And you've mentioned mainstreaming and support. how do we move that beyond just, I suppose, aspirations to making that happen? And not to put you in the spot, but I think for all of us in the sector, that would be a real interesting challenge. Thanks, Chris.
I don't have the answer there. I think that you already have, I mean, you have got something that a lot of funded services don't have. You've got a really strong database in terms of outcomes. So you can answer a lot of the questions in terms of outcomes. I think you need a health economist to translate some of those outcomes into savings, which is always important for commissioners. And I think that it is about, you've got very strong networks with all 5 trusts, and you need commissioning champions in those trusts. And most importantly, I mean, since the interim project evaluation, you have got service users and carers in your project board. And I think that they have often a much stronger voice than staff. So you've got all the networks in place. You need to be pushing at the door here in terms of mainstreaming that and showing how the outcomes that you have got map on to the needs of the trust and their and the Department of Health and their strategy and priorities for children in need, children with disabilities, and indeed the original brain injury review.
Lovely. Thanks very much, Chris. I know it's always very dangerous to get between people and audiences and lunchtime, but I want to say thanks to you, Chris, and thanks to all our speakers this morning. I think we've had really interesting, challenging and very comprehensive presentations from Chris, from education, from health, from the Brain Injury Matters team. So I think it sets us up very well for this afternoon. Over lunchtime, we're going to be showing a number of videos and case studies of the families that we've been engaged in. And again, be very keen if people stay on over lunch and watch those. We're returning at 1:15, and again, we'll move on through the afternoon, focusing more on the experience of young people and adolescents. So again, thank you all for attending this morning. I hope people can stay on, but as I said at the start of the day, we are recording the session, so we'll get a chance to come back to people and see the whole conference. So thank you, and look forward to seeing you all at 1:15. Thank you.
My name is Janet, and Brain Injury Matters have been tremendous for myself and my son since he took sick. On the 6th of March, when he came into the room, he took really ill and said he couldn't see and wasn't sure who anybody was, so I took him down to the A&E. He went into a self-induced coma for nearly 11 hours. I seen his eye flicker, and I said to him, "Eric, do you know who I am?" And he looked at me and he went, "Aye, Mummy." I think that was the best second of the whole day, you know. And then one morning he woke up and he says, "I see 2 of everything." The consultant phoned the Royal, and they come back to me and said, "Bit of a shock, Mum, be ready in 10. So when Eric ended up in the Royal, that's where the journey really began for us. We were given no point of call, support, anything. And I went up to somewhere in Belfast, can't remember now where, that had a hub of all different charities available to help people. And that is where I found Brain Injury Matters, and that's where they were at. They did a life book with him. They had pictures of him when he was a baby and when he was born, and then they had pictures of him when he was in the hospital, and pictures after he was in the hospital to let him see that there was life before he was sick. Okay, yes, you got sick, but guess what, Eric? There's life after it too. Brain Injury Matters has helped Eric understand how his brain is working now. Like Eric said to me recently, just that, "Mommy," he says, "like I'm not as angry as I used to be." And I go, "No, you're not," you know. And that has definitely been all down to the work of Brain Injury Matters, because they're the team that's been working with him. The future for Eric, I hope that he can live an independent, happy life, have a job, and look back in years down the line and feel that he did himself proud. Brain injury matters to my son and to me.
Well done. Now, your donations allow children in need to help support young people and their families when they need it most. And often this need can come out of the blue, a life event that no one was expecting. Brain Injury Matters NI promotes and empowers those affected by an acquired brain injury, helping them adjust to a life with their injury and achieve new goals.
My name is Rashin. I'm 15 years old. I live in Derry with my mommy, my daddy, my sister and 3 brothers.
Rashin is my really beautiful 15-year-old daughter. Up to the end of 2018, Rashin was a really high achiever at Thornhill College. She was top ability student in her class. At the beginning of 2019, on the 20th of January, a day that we will never forget, Rashin had a major stroke and it has caused life-changing disabilities to her.
Let's find a place where we can sleep for the night.
It's nearly difficult to put into words.
Look, somebody's coming.
The impact of an acquired brain injury can really affect any area of your life, socially, emotionally, cognitively. A lot of our young people would report having difficulty with fatigue, social interactions. A lot of our young people would find that they're quite socially isolated from their peers, difficulty with concentration and attention. There can be physical difficulties and physical changes following acquired brain injury.
There's such an adjustment with an acquired brain injury, and Brain Injury Matters have really supported us through all of that.
I met Susie in September 2019 and Susie's really helped me and she set goals for me, like building my confidence up.
The funding from Children in Need has been really supportive in helping us to develop the service and adapt to the COVID situation. We provide online service delivery via video call, telephone calls, and we've also created a youth council for some of our young people with an acquired brain injury. So they are planning and delivering online social activities, which has been going really well and helping to reduce that social isolation.
So they set up a youth group and I'm the treasurer, and the treasurer spends money on certain activities.
They have quizzes organised, they have games nights. Next summer they're hoping to go to an adventure park with all the families.
She has played a big role in the planning and delivery of those activities, which is just really lovely to see her confidence and her social interaction.
The big part about the youth group is that Rashin is meeting people her age that have an acquired brain injury. It has taught Rashin so much.
Susie's been a great help and support to me, and she's been really brilliant.
I can't emphasise enough, they have really helped me, they've helped Rashin, but they've helped my whole family. They've supported us in so much.